Good morning, everybody. Thank you all for being here. Good morning. My name is Sandro Galea. For those who I don't know, I have the privilege of serving as Dean of the Boston University School of Public Health. And on behalf of our school, welcome to today's event, today's Public Health Conversation. This is part of our series of public health conversations, which are meant as spaces where we come together to discuss the ideas that shape a healthier world. The goal is, through speech, discussion, and debate, we sharpen our approaches to building such a world guided by our speakers towards a better understanding of what matters for health today. We are very pleased today to thank our co-hosts, the Planned Parenthood League of Massachusetts and the BU Program on Reproductive Justice. We'd like to thank our moderators, Eleanor Klibanoff and Nicole Huberfeld, and we'd like to thank Professors Huberfeld, Aziza Ahmed, and Linda McLean, who were really the intellectual architects of today's event. Thank you to the Dean's Office and our communications teams, without whose efforts these conversations would not take place. Today's event is part of a series that we're doing this fall, which we're calling A Vote for Health. We are intentionally welcoming speakers who are guiding our thoughts on issues of consequence for health with the US upcoming federal election in mind. Today, we're going to discuss the 2024 election and its intersection with issues of reproductive health. The day is going to be divided into two sessions. Session one will be reproductive rights and the health of the public. We're going to hear from our keynote speaker and then have a panel discussion. Then we'll have a lunch break, and then we'll reconvene for our second panel and session two, which is called The Future of Reproductive Law and Policy. So we're going to start session one, and I'm delighted to welcome our keynote speaker, Dominique Lee, President and CEO of Planned Parenthood League of Massachusetts. Dominique became President and CEO of Planned Parenthood League of Massachusetts in 2023. An expert healthcare leader and innovative public health strategist, she has dedicated her career to expanding access to quality, compassionate, culturally sensitive healthcare at Planned Parenthood and advocating for health equity and social justice through public health and policy initiatives. Her appointment as President and CEO of PPLM is a full circle moment for her and a historic one for PPLM. Dominique started her career nearly 20 years ago at PPLM as a healthcare assistant and patient services manager. She launched a 17-year journey with Planned Parenthood that spanned 4 affiliates in red and blue states, urban and rural environments, of Indigenous and Chinese descent. She's the first person of color to lead PPLM as President and CEO. Throughout her journey, she has consistently intertwined health equity with wellness, branching into areas like reproductive health, social justice, economic principles, social capitalism, and a whole person approach to healthcare. And on a personal note, I've had the privilege of working with Dominique on the board of PPLM. I've very much enjoyed our work together and I see her as a visionary leader leading the organization forward. Dominique, welcome.
All right, good morning. Thank you so much for having me. Thank you, Dean Galea, and thank you to everyone putting this event together. I know what a massive initiative like this takes to put, so really appreciate everyone. It is an honor to be here at Boston University, an institution known for its commitment to shaping the future of public health and public policy. I'm Dominique Lee, President and CEO of Planned Parenthood League of Massachusetts. As I prepared my comments for today, I was reminded of the countless moments in my career where public health has proven its power to transform lives, not just as an abstract idea, but as a vital force that can mean the difference between life and death. Public health is often called the invisible profession, but for those of us drawn to this work, it becomes painfully visible when systems break down, when people are left behind, and when crises hit. We are the ones that step in, who confront the uncomfortable truths, and who speak up when others remain silent. And reproductive health is no different. It is public health. And so for me, like many of you I know, this work is deeply personal. I know what it's like to be denied basic rights, and more painfully, what it's like to feel powerless. That feeling of having no control, of being stripped of your own agency, is exactly what drives me to do this work every day, to make sure that no one has the same experience. When we talk about reproductive health, we are not just talking about healthcare. We are talking about human dignity, the right to live a life that is truly your own, on your own terms. And I couldn't be prouder to be doing this work in a state like Massachusetts, a state that has become a beacon of reproductive rights and health equity. Here, We are building a model of care and advocacy that not only provides vital services, but leads the nation in protecting and expanding maternal and reproductive health care. Our state is setting a standard for what is possible when we prioritize health as a fundamental right. But while we have made tremendous strides, we cannot forget the millions of people across the country who are still being denied this basic right. In many states, access to abortion and other reproductive health care is being stripped away, leaving countless individuals with fewer options and less control over their own bodies. And that's why I'm here today, because the fight for reproductive justice is inseparable for the fight for public health. It is about ensuring that every person, everywhere, has the right to access the care that they need, free from political interference and systemic barriers. So, let me introduce you to two women, both named Michelle. The first, Michelle, lives in Brighton, Massachusetts. She's 26 and recently moved here to pursue her dream of becoming an architect. After moving in with her boyfriend, they were overjoyed to learn that she was expecting. But during her 10-week ultrasound, Michelle received devastating news that she had an ectopic pregnancy, a dangerous condition where the fertilized egg actually implants outside of the uterus. This type of pregnancy is non-viable and can lead to severe, even life-threatening complications if not treated immediately. However, since she's here in Massachusetts, Michelle's doctor immediately explained the procedure to treat the ectopic pregnancy, ensuring both her health and preserving her reproductive future. There was no judgment, there was no hesitation in prioritizing her well-being, and there was no delay in providing the care she needed. Although this wasn't the pregnancy that she and her partner had wanted or envisioned, Michelle knew that they could try again when she was ready. Now, let's talk about another Michelle from Austin, Texas, also 26 and looking forward to starting her family after recently marrying her partner. They were thrilled to discover she was pregnant, but at her first ultrasound, she received the same heartbreaking diagnosis, an ectopic pregnancy. So in Texas, the law technically allows doctors to terminate ectopic pregnancies, but the climate of fear and legal restrictions surrounding abortion means doctors often hesitate to act unless the patient's life is already in danger. Though acknowledging that the pregnancy was non-viable and incredibly dangerous, Michelle's doctor explained that they could not treat her while her cardiac activity was still detectable. Desperate, Michelle sought a second opinion, but by the time she was seen, her fallopian tube had ruptured. She was rushed into emergency surgery, losing several pints of blood and her left ovary. Now, Michelle may never be able to conceive naturally again. So let's just take a look at the unbelievably stark differences between these two women, both with seemingly identical stories, yet dramatically different outcomes. What Michelle endured in Texas is unacceptable. And I think we can all agree it's unacceptable anywhere. No one should have to face this type of trauma, fear, or delay when it comes to life-saving healthcare. Doctors should not be forced to deny their patients evidence-based medical care ever. What happened to Michelle in both Texas and Massachusetts mirrors the experiences of so many others across the country. These stories highlight the critical importance of reproductive rights and access to healthcare for all. No one should have to fight for their life because of where they live. So let's dig into where we are in this very moment. On June 24th, 2022, the Supreme Court overturned Roe v. Wade, dismantling nearly 50 years of protection and precedent. The federal constitutional right to abortion was snatched before our very eyes. And today, 2 years later, millions of women, trans, and non-binary people are living in states that ban abortion care to some capacity, meaning they are forced to travel hundreds, sometimes thousands of miles away to get care, or to continue the pregnancy against their will. So let's pause for a moment and truly reflect on the reality that we are facing in the aftermath of the Dobbs decision. The numbers are staggering, but behind each statistic is a person, a family, a community. 22 states have abortion bans. 43% of women of reproductive age, as well as trans and non-binary people, live in these states. That is 29 million women whose fundamental right to control their reproductive health has been stripped away. And now, 1 in 5 people seeking an abortion are now forced to travel out of state for care, crossing state lines for care that they should be able to get at home. And here in Massachusetts, we saw a 37% increase in people traveling to our state for abortion care in the months immediately following Dobbs. These aren't just numbers. This is a national health crisis driving people to their breaking point, forcing them to miss work, gathering what little they have to try to travel, and enduring the emotional and mental toll of navigating a system designed specifically to deny or delay them care. This is not just a policy failure. This is a humanitarian failure. These are real lives on the line, real futures being shaped by political decisions that strip away personal autonomy. And nowhere are the consequences of abortion bans more devastating than in communities of color, especially for Black women, trans, and non-binary people. We know they are already battling a system steeped in inequities and injustices, and these communities are now facing even greater risks. When reproductive and maternal health care is restricted, the results are catastrophic. 54% of Black women, trans, and non-binary individuals live in states where abortion is not just restricted, but it is outright banned. That is 4.8 million Black people trapped by oppressive laws, forced to either travel hundreds of miles to access care or endure the dangers of carrying an unwanted pregnancy or a dangerous pregnancy. These bans do not simply restrict access, they compound an already existing crisis that disproportionately devastates Black communities. Black women in America already face a maternal mortality rate 3 times higher than white women. And now, with abortion access ripped away, their ability to lead healthy, joyful lives is further jeopardized. They are being forced into life-threatening situations made to risk their health, their futures, and their families. This is not only a violation of healthcare rights, but it is a deliberate assault on their right to opportunity, to safety, and to self-determination. And let's be absolutely clear. This is not just a healthcare crisis. This is a racial justice crisis. When laws are designed to disproportionately harm the most marginalized among us, we are witnessing the continuation of a system steeped in systemic racism. The fight goes beyond just a medical procedure. It's about the fundamental right to autonomy over one's own body, choices, and futures. It's about ensuring that everyone has the power and the opportunity to a life defined by health, happiness, and potential. Not just as a privilege, but as a basic fundamental human right. The pursuit of reproductive freedom is deeply intertwined with the broader struggle for racial justice. And our commitment to both must be unwavering and resolute. This is more than just about survival. It's about liberation. It's about tearing down the structures that have long denied traditionally marginalized people the opportunity to live with power, with joy, and with dignity. This is a battle for the soul of justice itself. We must rise together now with everything we have, because the stakes cannot be higher.
This fight is the right of every person to lead a life of freedom, health, and boundless opportunity, and we cannot afford to lose. In the past 2 years, here at Planned Parenthood League of Massachusetts, we have been working to expand access to reproductive and gender-affirming care. And those advances wouldn't have been made possible without strong partnerships. We've worked with healthcare providers, community organizations, and policymakers to protect those on the front lines of reproductive health from legal threats. And together, we've fought to ensure that insurance covers abortion services and expanded access to medication abortion, emergency contraception, particularly on college campuses like this one. And through collaboration with state leaders and advocacy groups, we've secured increased funding for reproductive healthcare providers. We strengthened the Roe Act to support patients who need abortion later in pregnancy due to complications. And we passed legislation to allow pharmacists to prescribe contraceptions. And we also pushed the state to adopt inclusive, medically accurate, consent-based guidelines for sex education in public schools. And while we have made progress, it is still not enough. Access to healthcare, particularly reproductive healthcare, remains out of reach for far too many. And while Massachusetts has led the way, we still have work to do. And the battle continues across the country, where too many communities of color, low-income individuals, and marginalized groups are struggling to access even the most basic healthcare. Every person, no matter where they live, deserves the right to make decisions around their own bodies and futures, free from political interference. And let's be clear, no politician is ever more qualified than a patient and their healthcare provider to determine what is best for their health, their body, and their life. Reproductive choices belong in the hands of the people directly impacted, not in the hands of lawmakers. So, as I close, I want us to return to the two Michelles, two lives shaped by the same dangerous truth, that where you live can determine whether you survive. These stories are not just about healthcare. They are about the fundamental rights to life, safety, and dignity. And as we stand at this critical moment, we must confront the harsh reality that reproductive justice and public health are under siege in this country. This is not just a theoretical issue. It is happening right now, and it is costing lives. I know many of us saw just in these past weeks, ProPublica reported the tragic death of Amber Thurman, a 28-year-old mother from Georgia who died after being unable to access legal abortion care. Her death was deemed preventable, with delays in care playing a significant role in her death. And her story is not unique. Candy Miller, a mother of 3 with lupus, diabetes, and hypertension, was warned that another pregnancy could be fatal. But Georgia's abortion bans left her with no options. Forced to attempt an abortion on her own, Candy suffered complications and tragically died. Her family, believing the state's restrictive laws kept her from seeking the very care that she needed. It is these heartbreaking stories that highlight a devastating pattern where restrictive abortion laws are putting people's lives in jeopardy. Amber and Candy should still be alive with us today. These lies are not just denying care, they are creating a deadly reality for far too many. And while public health may be called the invisible profession, today we must make it unmistakably visible. We must reject policies that strip people of their rights and perpetuate harm, particularly in communities of color. We must fight a system that prioritizes politics over people's lives. This upcoming election isn't just about voting. It's about defending the future of our society, of our families, and our ability to thrive. We cannot accept a world where stories like Michelle's in Texas, or Candice and Amber from Georgia are the norm. We must challenge the status quo and reject complacency. We must fight for a future where every person has the right to control their body and where providers are not forced to hesitate or fear criminalization when offering life-saving care or life-affirming care. We cannot afford to be silent. We must fight with everything for a future where justice prevails, where no one's health is sacrificed for political gain, and where we protect what truly matters, our humanity. And let us not forget your power. The power to change these unjust systems begins at the ballot box. Voting is one of the most powerful tools we have to dismantle oppression, protect reproductive rights, and ensure racial equity. Every election is an opportunity to choose leaders who will fight for justice, who will stand up for the most marginalized among us, and who will ensure that the future is one of dignity, one of freedom, and one of opportunity. Our voices, our votes, and our power. Let us use them to transform this fight into lasting change, to propel our society forward and our humanity forward for generations. Thank you.
Thank you, Dominique, for that excellent introduction to the day, and thank you for everything you do. I'm now pleased to introduce the moderator of our first session, Eleanor Klibanoff. Eleanor is a women's health reporter for the Texas Tribune, based in Austin, where she covers abortion, maternal health care, gender-based violence, and LGBTQ issues, among other topics. She started with the Tribune in 2021 and was previously with the Kentucky Center for Investigative Reporting in Louisville, where she reported, produced, and hosted the Peabody-nominated podcast Dig. Eleanor has worked at public radio stations in Kentucky, Pennsylvania, and Missouri, as well as NPR, and her work has aired on All Things Considered, Morning Edition, and Here and Now. Eleanor was born in Philadelphia and raised in Atlanta and attended George Washington University in Washington, D.C. Eleanor, we're delighted to have you with us. Welcome.
Thank you, Dean, for that kind introduction. I'm thrilled to be here in Boston for this important conversation. I now have the pleasure of introducing our Session 1 panelists. First, we will hear from Vanessa Robinson. Dr. Robinson is a health equity research scientist with over 15 years of public health experience. She serves as an assistant professor of public health and community medicine at Tufts University School of Medicine. In both her teaching and her research, she centers the use and establishment of equity initiatives to optimize sexual and reproductive health and nutritional health justice. She has contributed to the early stages of development for the Mother Lab, one of the nation's largest labs dedicated to optimizing maternal health outcomes for Black women. Dr. Robinson is also the chief report editor and lead technical writer of the report of the Special Commission on Racial Inequities in Maternal Health via her ongoing partnership with colleagues at the Massachusetts legislature. Then we will turn to Janelle Palacios. Dr. Palacios is a nurse midwife, researcher, lecturer, and storyteller, originally from the Flathead Indian Reservation located in Montana. Dr. Palacios is the founder of Encoded for Story and co-founder of Square Root Stories, story-based consulting firms helping individuals and organizations link the importance of history and story to address and improve maternal child health outcomes. Third, we will hear from Payal Srinivasa, Reproductive Health Medical Director at Fenway Health. Dr. Srinivasa's areas of expertise include full-spectrum obstetric and gynecologic care with interest in family planning, preconception care, contraceptive management, preventative health care, and cancer screening. Dr. Srinivasa is passionate about trauma-informed care and healthcare innovation, which improve patient engagement and promote health equity. Finally, we will hear from Ushma Upadhyay. Dr. Upadhyay is professor at University of California, San Francisco in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and core faculty of Advancing New Standards in Reproductive Health. She's a public health social scientist trained in epidemiology and demography, has experience in abortion safety, abortion access in the US, medication abortion, and state-level abortion restrictions. She's principal investigator of the CHAT study, which evaluates the safety, effectiveness, and acceptability of telehealth for abortion in 20 states. She's also leading a study on interest in a late period pill and is co-director of the University of California Global Health Institute's Center for Gender and Health Justice. With that, we will now turn to our individual presentations. The floor is yours, Dr. Robinson.
Hello, everyone. Thank you for having me, to the BU administration, faculty, staff, students, and all who are joining us today. As previously mentioned by Eleanor, I'm a health equity research scientist, so I'll be presenting information based from that perspective. Also mentioned, I'm an assistant professor at Tufts University School of Medicine. I am the co-author of the written proposal, which directly led to the establishment of the inaugural Center for Black Maternal Health and Reproductive Justice at Tufts. I serve as the public health advisor for a birthing app known as Birth by Us. This app particularly centers the health and wellness for Black birthing mothers across the United States. And finally, I'm the principal investigator of a research study called BRGI, or affectionately known as BRGI, which stands for the Black Rainbow Justice Initiative. This study it's an observational study that assesses the needs and perspectives of Black LGBT persons that are interested in family planning. You will hear us talk a lot about reproductive rights on today. For the sake of our conversation or this presentation, I will be particularly looking at areas of the right to contraception, the right to abortion, the right to sexual education, and the right to reproductive privacy. We are in a maternal health crisis, and we're in a maternal health crisis for a few reasons. Despite the United States being the top when it comes to healthcare spending, it doesn't necessarily mean that we're the top when it comes to performance. Maternal mortality is included. For example, we rank high when it comes to maternal mortality. The number of women who die giving birth in America over the past decade has doubled. More than 80% of maternal deaths are preventable. In other words, these deaths did not have to happen. And finally, as my colleague Dominique mentioned, Black women are 3 times more likely to die from pregnancy-related complications compared to their white counterparts. And we are steadily seeing the ongoing effects of the Dobbs versus Jackson Women's Health Organization, also known as the overturning of Roe versus Wade. Some highlighted laws to pay attention to, of course, is the overturning of, Roe versus Wade, which was a 1973 Supreme Court decision that basically legalized abortion. As of June 22, there was an overturning of that in the Dobbs case. So what are the actual impacts on maternal health outcomes? When we look at the Roe versus Wade, for example, we see that it expanded the right to privacy. The right to privacy being that people had the right to decide whether or not to follow through with a pregnancy, and also the right to protection against governmental interference. We also saw reduced mortality. In 1965, for example, abortion was so unsafe that about 17% of all deaths due to pregnancy and childbirth were the result of all illegal abortion. After the implementation of the law, less than 0.3% of women who underwent legal abortions at all gestational ages sustained a serious complication requiring hospitalization. We also saw an improvement in equity, as about 9.6% of Black women had increased their college graduation rate, according to a study conducted by the Institute for Women's Policy Research. And we saw about a 7% increase in Black women's labor market participation rate. When we look at the Dobbs versus Women's Health case, that is the most current decision, the decision has led to an abortion access, a reduction in abortion access in many parts of the country. In just a few moments, I'll give you a visual representation of where we are. As of April 2024, 14 states have banned abortion, 11 states have limited abortion to a certain gestational age. And finally, maternal death rates and abortion restrictions were 62% higher than in states with greater abortion access. What are some ongoing potential impacts that we can see or that we expect to occur? Unintended pregnancy is one. As contraceptive needs go unaddressed, unintended pregnancy is likely to occur. Based on global data, abortions probably won't stop, but instead people will seek less safe means to acquire abortions. And finally, medical school graduates without abortion training will be limited in the skills that are necessary to manage pregnancy complications. This includes placental abruption, infection, ectopic pregnancy, and eclampsia. Because the same medications and surgical techniques used for abortion also treat obstetric complications. As I previously mentioned, this is where we are in terms of abortion legality by state. When you look at the outer parts of the US, you see that those states tend to have expanded access and protected access. However, when you look at southern parts of the United States, as well as the Midwest, you see how those policies become more hostile or illegal altogether. Now I'd like to show you a representation of the support on abortion legality. And this data was gathered from 2010 to 2023 based on political party affiliation. Democrats have consistently been in favor of abortion rights, though their support has increased over time. Since 2010, for example, at least 2/3 of Democrats have supported a woman's right to abortion in all or most cases. Those who identify as Republicans tend to oppose abortion, with the minority who say abortion should be legal in all or most cases. Some state constitutions independently protect abortion rights. The state of Massachusetts is one example. So whether a person lives in the state of Massachusetts or they're traveling from another state, they can access abortion in Massachusetts. In terms of the progress we've made in maternal health altogether, recently, Governor Maura Healey signed what is known as an act promoting access to midwifery care and out-of-hospital birth options. This comprehensive legislation is expected to overhaul maternal health practices in Massachusetts and expand coverage for midwifery, birth centers, doulas, and screening and treatment for postpartum depression. This legislation would require Mass Health to cover doula services for pregnant people up to 12 months, and also include any member who recently became pregnant or lost a pregnancy. So what do you all need to know in going into the 2024 election? You need to know a lot. However, I don't have the time to cover all of that. But one thing you need to know is the power of the president. A strongly pro-life or pro-choice president, for example, can lead on the issue through their rhetoric and policy choices. The president, for example, has the power to appoint federal judges, including appeals judges. As an example, in January, an appellate court ruling in Texas allowed the state to ban emergency abortions. The president also has the power to work with federal agencies in Congress to protect reproductive rights. These include life-saving care and IVF, or they also have the right to work with those to take away drugs that manage abortions and miscarriages. And I'll leave you with a final quote from a professor of law out of the University of Buffalo, Lucinda Finley. If the party that is opposed to abortion wins the presidential election in November and takes control of the federal government, the president would appoint what is called a head of Health and Human Services. And if that person is anti-abortion, then that department could issue a regulation prohibiting college health services from distributing or allowing reproductive health services, including backups such as Plan B. Beyond access to campus health care, this election could impact the next 30 to 40 years for college students as it affects the entire reproductive lives of young women in the U.S. and their partners. And I'll leave you with this. I just came up with it off the top of my head, but I think it's important for you all to know. Vote as if your life depends on it, because it does. And for those of you all that are beyond reproductive age, your legacy depends on it as well. Thank you.
Thank you. It's an honor to be here at Boston University with you today. And thank you, Dean Galea, and thank you to all my colleagues here. It is amazing to just spend a little bit of time with each of you and get to know what each of you are doing, because you are moving the world. You are shaking up what's going on in Boston right now, but this is going to have ramifications down the road and for our futures. And thank you for being on this path. Nearly 50 years ago, a group of Native American community organizers held a convening to outline what tribal sovereignty meant. Now, this meeting was coming off the back of a series of injustices and federal policies that had debilitated many Native American communities. And there was a movement to reclaim tribal sovereignty. This is going to connect to everything, okay, everyone? I know this is a little rough, but every time I get a podium, I get a chance to talk about tribal sovereignty, because it has direct impacts on Native American women, their children, and futures. So, as one young Akwesasne Mohawk woman, in particular, was struck by what she heard, and she came up with this term, personal sovereignty. We can conceptualize this today as bodily autonomy, bodily sovereignty, but Katsi Cook, the young mother, a person with lived experience and knowledge from her community, saw parallels in the need to frame personal sovereignty into sovereignty over our own bodies. Each and every policy you see listed here directly and indirectly impacted Native American women's bodies. She understood the first policy enacted sought to remove Native people from their ancestral lands, disenfranchising them from their resources, their ancestral places, their spiritual places. As capacity for a stronger US nation came together, greed and desire for the surrounding land became the goal, and relocation policies intermixed with some extermination policies. Outright extermination policies happening in California, wiping out nearly most of Native people in California. The scorched earth policy burned homes and crops, killed food sources such as bison and sheep in order to weaken tribal strength and keep Native people from coming together in large numbers, but also prime them to leave their homes and to give up their children. Eventually, the federal government turned into assimilation policies. Strings attached land ownership, promoting nuclear family, religious practices, forced removal of children into boarding schools, and displacement of Native children into foster care. In the 1950s, the federal government terminated a number of tribes, encouraged families to leave reservations for cities, and promised housing and job security, which lasted for a few months and then support withdrawn, essentially stranding many Native families in urban areas. Finally, in the 1970s, the federal government supported self-determination policies, or the ability of tribes to enact their sovereignty. See, Native people, tribal nations, we have a vested interest in sovereignty. Many policies have tried to erase us. And we see this today when we see that our numbers are missing from state and national reports. You may not know this, but depending on where you are, Native women die 7 times the rate of white women from maternal health complications. It depends where you are and how you identify the population, and we are simply not recorded. At this intersection of policies, we see Katsi Cooks. She is just coming to this term, personal sovereignty. Headlines detail what many Native American already knew firsthand, coerced sterilization that took away between 25 to 50% Native women's childbearing ability. Like Black women, Native women faced targeted sterilization, coercive practices enrolling them into contraception trials for medical experimentation. Like Black women, Native women continue to experience family separation and forced removal of children, so much so that a law was enacted to try and protect Indian children, but this does not protect all Native children. We both are patients of government-controlled and regulated healthcare. Women who receive care from Indian Health Services or have Medicare pay for their health operate under restrictions under the Hyde Amendment. Abortion services are not fully accessed. Pressure to control the size and timing of our family with long-term acting reversible contraception and environmental hazards that gravely affect our own health and our children's health, whether you have access to clean running water, electricity, broadband internet, pollution-free environments, safe housing, we have shared experiences and shared outcomes. We walk together. Of course, we experience these harms and outcomes because we live in our inherited life context surrounded by structural racism. We can do better as a nation. We can address structural racism. We can walk together. Where do we go? How do we achieve safe and equitable abortion access? We walk together, not just those who are marginalized, but everyone. Framing this discourse in compassionate care and public health is critical. How do we move voters? We walk together. Does government belong in the decisions one makes about our bodies? Imagine being pregnant and told you must start antibiotics because you have a common bacteria that has been shown to elevate the neonate's risk for infection. You don't believe in taking antibiotics. You decline them. Imagine you're expecting your first child, and after doing your own review of online chat boards, reading a few news articles, a few baby preparation books, and speaking to women from your church, you decide you want to wait for spontaneous labor, and you are now 43 weeks pregnant. You decide to wait for spontaneous labor. And you are told by your provider that out of every 1,000 pregnancies at 43 weeks and above, 14 babies will be stillborn. But that's not you. You decide to wait spontaneous labor. Imagine you are pregnant with uncontrolled diabetes and actively choose not to take insulin. Not taking insulin when indicated can elevate the risk of a fetal demise. Each of these decisions were made by the pregnant person. Each of these decisions could end in fetal death, or in the case of antibiotics, could put the neonate at risk for sepsis and ultimately death. Does government belong in each of these decisions? Native American and Black women are not strangers to surveillance and policing. Whether it is the neighborhoods we live in, the social services we seek, healthcare we access, or simply sitting in our cars or walking into a store. Our children and our partners and our very bodies are always in a state of surveillance. Do the rest of the women in this country want to join us? Or is it time we end these practices? So let's walk together. Thank you.
Good morning, everyone. My name is Piles Srinivasa. I'm thrilled to be here as a Boston University School of Medicine alum. I also trained here as an OBGYN resident. It is where I spent some of the most formative years of my career, so this feels like a little bit of a homecoming. Thank you again. I don't have any disclosures, but I just wanted to kind of revisit that I work at Fenway Health, and Fenway Health advocates for and delivers innovative, equitable, and accessible healthcare and supportive services. We really focus on LGBTQIA+ populations, and I'm here as a proud ally and ambassador of Fenway Health. I also am an abortion care provider and have been my entire career, but interestingly, Fenway is a federally qualified health center. So in my last 1.5 years as a medical director of OBGYN, I have not been able to provide abortion care. And I'm here today to advocate a little bit about how we can kind of figure out how to make that happen. My slide notes are not displaying. There's a little bit of a lag in my presenter screen, just so everyone knows. So my personal why, I am a mother by choice. And I really hope that my daughters are able to kind of grow up in a world that is more tolerant, and for them to look at the world through a lens of compassion. I understand that some of the topics that we will discuss today may bring up some friction or discomfort, but I do think that some of that discomfort can birth discovery learning, and innovation. So we're going to talk a little bit about unique considerations for reproductive health and abortion care in transgender and gender diverse populations, and review some terminology that is not so gendered and gender affirming, and define trauma-informed care and essentially build a case for trauma-informed care in care delivery for transgender and gender diverse patients. So the US Trans Survey is the main source of data about transgender people covering health, employment, income, criminal justice system. And some key takeaways from the most recent trans survey indicate that our transgender and gender diverse populations are suffering. There's pervasive mistreatment and violence. They suffer severe economic hardship, harmful effects on both physical and mental health. Nearly 30% of respondents have experienced homelessness. 7% of respondents had attempted suicide in the past year, and 40% over their lifetime, which is 9 times greater than the general US population. Nearly half of respondents report having had a negative experience with a healthcare provider, and around a quarter of respondents reported issues with gaps in health insurance or health insurance coverage. Likewise, nearly a quarter of respondents reported not seeking healthcare due to fear of mistreatment and had to teach their healthcare providers about transgender care. All of these factors contribute to inadequate care or substandard care. In addition, I thought it was a little bit horrifying that nearly a quarter had to kind of teach people how to take care of them. So the World Professional Association of Transgender Health, in its most recent publication, has created recommendations around reproductive health for trans and non-binary people, including advocating for reproductive rights, gender-affirming care, and referral to and/or provision of abortion services. So all humans, including transgender individuals, have the reproductive right to decide whether or not to have children. This slide summarizes a study which retrospectively examined pregnancy experience in trans men. I think it's important to understand that a third of the pregnancies were unplanned, and in general, there was a lack of provider and peer support for trans men experiencing pregnancy, along with significantly worsening gender dysphoria. Data on abortion care experience in transgender and gender diverse patients is overall lacking. This slide summarizes a retrospective study of nearly 1,700 trans and gender diverse people. Of those included, 210 people reported 433 pregnancies, and 21% of these ended in abortion. Interestingly, although medical abortion was preferred 3-to-1, a fifth of the reported abortions occurred past gestational limits to medication abortion, potentially related to lack of access to timely care or delayed diagnosis of pregnancy. 20% attempted self-managed abortion, which is an incidence that is 9 times greater than cisgender women. Finally, authors noted that patients reported worsening gender dysphoria and lack of affirming care. So we're going to move on a little bit and talk about ways to support an affirming care environment for gender diverse individuals. I think many of you already know that sex, gender identity, gender expression are increasingly being described as being on a continuum. And gender affirmation is defined as the process by which individuals are affirmed in their gender identity or expression, and has social, medical, and legal components. So examples include name change, how one presents themselves externally, gender affirming hormonal therapy or surgical treatment, and legal affirmation, such as changing legal documents. Examples of offering an environment in healthcare, or frankly, any setting, includes use of non-gendered language, diversity education, which includes gender identity, pronouns on IDs, and use of electronic medical records with correct identifiers. Many, many subtle factors can contribute to an environment that is perceived as welcoming or exactly the opposite. And at work here at Fenway, my badge includes my pronouns, and I wear a small pin that includes my pronouns, which just opens a window and often puts people at ease. So this lists some examples of gendered language and examples of language that might be less gendered or affirming. So the big one is women's health. and kind of potentially moving away from that. That's a little bit controversial. Some people like the term woman and they feel very married to that. People don't know what reproductive health is. Sometimes when I say I'm a reproductive health director, they don't understand that that's an OBGYN. So I think in my conversation with one of my fellow panelists, we talked about how probably our current vocabulary doesn't support totally non-gendered language, but there's a lot of work to be done. So again, we're going to shift gears one last time and talk a little bit about trauma and trauma-informed care, and hopefully build a case for a trauma-informed approach to reproductive health care for trans and gender diverse patients. So the Substance Abuse and Mental Health Services Administration is the agency within the U.S. Department of Health and Human Services that leads public health efforts to advance the behavioral health of the nation. And SAMHSA defines trauma as an experienced event which has lasting effects on various aspects of functioning. Trauma is ubiquitous, with nearly 90% of the US population having experienced trauma. Nearly half of LGBTQIA+ patients report a history of complex medical trauma, with leading causes being violent assault, sexual assault, childhood sexual assault. Trauma leads to chronic physical and mental health conditions and increased mortality, decreased sense of safety, autonomy, and trust in the healthcare system. Etiologies of trauma range from overreaching, like war, natural disasters, racism, and more individual or interpersonal, like being a victim of domestic violence or workplace bullying. Adverse childhood experiences, which is kind of a subset of trauma, or ACEs, are a type of trauma experienced in childhood that are known to have a direct impact on behaviors, like increased risk of drug abuse, lack of physical activity, and resulting physical and mental health outcomes in a dose-dependent fashion. So the greater the number of ACEs one experiences, the greater the risk of these adverse outcomes. We know that transgender adults have 2 times higher rate of ACEs, and I would advocate for keeping trauma-informed care top of mind when caring for them. So trauma-informed care is a framework for supporting patients that have experienced trauma to build resilience. It emphasizes empowerment and a collaborative relationship building. There are several key principles that define trauma-informed care, including safety, both physical and psychological, trust, transparency, collaboration. It's really kind of a huge paradigm shift from what's wrong with you to what happened to you or what's right with you. And the idea is really to empower patients by continuing to build trust, and these are the steps that are often the basis for creating true cultural change. The 4R framework includes realizing the impact of trauma, recognizing signs of trauma, responding on an individual and policy and practice level, and resisting re-traumatization. That, I think, in the healthcare system is particularly important. People are traumatized in the healthcare system every single day. So just a few bullets on kind of what trauma-informed care really means. It means maintaining appropriate eye contact, keeping hands visible so that sometimes hidden hands can be really triggering in someone who has suffered a physical assault, appropriate distancing, identifying what a patient's concerns are about an exam or what even a discussion of an exam would look like, agreeing to goals of the visit and reviewing what strategies patients would like to communicate with, explain what will happen during a physical exam and why. I think a lot of times providers don't even know why they do some of the portions of the physical exam that they do. So I think that's really important to hold ourselves accountable. For transgender patients, ask them what terms they prefer for their own anatomy or their own relationships. Ask patients if they feel comfortable. Do you want a friend with you? Do you want some music to listen to? And using simple clinical language can be really transformative. So to summarize on a high level, it's important to listen, avoid assumptions, and individualize the approach when caring for transgender and gender diverse patients, acknowledging prior trauma and resisting re-traumatization. So the key takeaways, promoting affirming care in communication and signage in exam rooms. Inclusion is never enough. We need to go kind of one step further. Transgender and gender diverse patients face some of the same health issues as their cisgender peers, but often substantially more bias. Consider a trauma-informed care approach. I think everyone can benefit from a trauma-informed care approach, given how ubiquitous trauma is. And planning ahead, informed anticipatory guidance about fertility, pregnancy planning, reproductive options, abortion care, and impacts on gender dysphoria are essential in caring for transgender and gender diverse patients. So I leave you with, by elevating the care of those that are marginalized or disadvantaged, all patients stand to benefit. Thank you so much.
Hello, everyone. Thank you so much. My name is Oshma Upadhyay, and I am so grateful to be here. I grew up in Boston. I grew up in Newton. My mom's here. So it's a really nice homecoming for me as well. Okay, so I'm going to be talking a little bit about a paradox of, thank you, paradoxes with the current situation in abortion. I'm going to talk a little bit about the impact of the Dobbs decision on abortion incidence and the impact of Dobbs on maternal and infant outcomes. But first, I want to talk about why abortion is a public health issue. There is a bounty of evidence demonstrating that abortion is good for people's health and well-being. It also has impact on the social determinants of health. Most of what I talk about on this slide and the connection to public health is from the Turnaway study, which is a study that was led by one of my colleagues at UCSF. Being denied an abortion impacts people's health. Women denied a wanted abortion have more anxiety and lower self-esteem at the time of abortion denial. They have worse physical health. Being denied an abortion impacts people's financial well-being. Women denied a wanted abortion are more likely to live below the poverty level, are more likely to report that they can't afford basic living expenses. Do you scroll down? And they're more likely to be evicted, declare bankruptcy, have a lot more debt, and they're also less able to provide for their existing children. Being denied an abortion impacts people's families. They're less likely to have an intended pregnancy in the next 5 years. They're less likely to be in a very good romantic relationship with any partner. They report worse maternal bonding with children born from unwanted pregnancy. Being denied an abortion also impacts people's future plans. People who are denied a wanted abortion are less likely to set aspirational plans. So check out the Turnaway study if you have a chance. So despite these public health harms, as has been mentioned by a couple of the previous presenters, today there are 14 states that have banned abortion completely and an additional 4 that have 6-week bans. Okay, so in response to those bans, other states have passed supportive abortion policies, a slew of laws to expand access. Some of these are now newly allowing Medicaid dollars, state Medicaid dollars to cover abortion. And then other states have also are providing increased funding for patients who are traveling from out of state, like Massachusetts, California, and Illinois. But in my opinion, probably the most of the impactful policies has been the rise of telehealth shield laws that are now enacted in 8 states, thanks to the work of David, who we'll hear about this afternoon. So these laws reduce legal risks for clinicians who provide abortion to patients living in states with abortion bans. And many of you know that Massachusetts was the first to pass one of these heroic laws. So it means that providers in states with a shield law can provide medication abortion via telehealth to people living in states with abortion bans. So in a telehealth abortion, just outlining the process, the ultrasound, the in-person ultrasound is replaced with history-based screening. The patient provides their medical background. Instead of receiving the pills in person, the patient receives the pills by mail. And regardless of whether the patient gets pills in a clinic or in the mail, the patient will have their abortion at home privately. And 4 weeks later, the patient will take a pregnancy test to confirm success. So our research of over 6,000 patients in 20 states across the country found that telehealth dispensing is just as safe and effective as in-person care. These data are from an abortion facility database that is maintained at Answer, and it's also available on request to journalists and researchers. So the number of telehealth providers has increased significantly since COVID and also since Dobbs. In the graph, the darker line represents brick and mortar facilities. The orange line represents all facilities, including those of virtual clinics. So you can see there's a pretty huge rise. And so this is part of the paradox that I was talking about. Additionally, our database has found that telehealth is significantly less costly for patients, and cost has always been the greatest barrier to abortion care. So obtaining a telehealth abortion is about $150 compared to $600, the national average of $600 for an in-person medication abortion. So I'm going to shift to talking about the incidence. I am co-chair of the We Count project, which is sponsored by the Society of Family Planning and aims to examine shifts in abortion volume over time. It's basically a census of anyone who offers abortion care: independent clinics, Planned Parenthood affiliates, telehealth providers, hospital systems, and private doctors' offices. So in the dark blue line is the monthly number of abortions, and the orange line reflects the monthly number of abortions, including those provided under SHIELD laws. So you can see the bump that the SHIELD laws, like Massachusetts' law, is providing in terms of the number. And you can also see that overall, the monthly number of abortions has steadily increased over time. This is more of the paradox. So for the first time, possibly ever, the monthly number of abortions surpassed 100,000 in January 2024. And this is the breakdown of in-person abortions, including both procedural and medication abortions, in the dark blue, in person, and then the yellow is the telehealth abortions. So you can see that, the in-person abortions are pretty steady. When this model first came about, people were concerned that the telehealth would take the place of in-person, but actually overall it has expanded access. I'm going to shift to the other side of the paradox, the impact of Dobbs on maternal and infant outcomes. The many ripple effects of Dobbs on healthcare. We're at a point where providers cannot work without their state legislators looking over their shoulders, and it impacts all types of pregnancy care. These are headlines from over the years, a slew of media reports about people not getting standard maternal pregnancy care due to abortion bans. And then as we heard earlier, and it bears repeating, Kavita Surana, an amazing reporter at ProPublica, has done some incredible reporting on two women in Georgia, Amber Thurman and Candy Miller, who both lost their lives in Georgia due to the state's abortion ban. So it's important that we really shine a light on these cases. This is a report that Answer just published. It has 86 reports from healthcare workers about poor quality of care. Check it out. It really provides and illustrates how abortion bans have a tremendous impact on delays for life-threatening pregnancies, ectopic pregnancy, pregnancy loss, and preterm labor. And another recent study from Alison Gemmel and colleagues from Johns Hopkins looks at the impacts of abortion restrictions on infant mortality. So because the data take a couple years to come out, we still don't have 2023 data yet. This data is from 2022 and looks at the impact of Texas's SB 8 law, which imposed a 6-week ban. And so what you can see here, because it was the first state, you can separate out the impact of the state's ban. And Texas's infant mortality shot up, you can see, between 2021 and 2022 compared to the rest of the country. So the authors explain that many of these deaths were among infants with fatal conditions, and women were forced to carry these pregnancies to term, only to see their infant die. These are data from the National Center for Health Statistics, and you can see that in every racial and ethnic group, infant mortality increased between 2021 and 2022 after Dobbs went into effect. So, in summary, abortion volume is higher in 2024 than in 2022, or 2023, 2022. The SHIELD laws really have played a pivotal role in access for residents in states with bans. The majority of abortions, though, continue to be in person, so we can't lose sight that it's a tremendous burden, the travel, the having to take time off of work to reach an abortion provider that's about 8 hours away. And then finally, the tremendous burden on maternal morbidity as well as infant mortality. Thank you. I'm just going to leave you with this picture of the first sitting vice president or president ever to visit an abortion clinic. This was in Minneapolis. Yeah.
Well, thank you all for those phenomenal presentations. Let's get another round of applause for our speakers. It was, really represented the wide range of issues that we are sort of talking about here. We are going to do some Q&A, but we will also open it up to the audience for Q&A when we have a little bit of time left. So if you are on the Zoom, you can put your questions in the Q&A function. And if you're here in the audience, we'll just come to you guys with a little time left. There are microphones that will run around when it's time. Several of you all brought up something that I think is on many of our minds today, which is Amber Nicole Thurman and Candy Miller, these women in Georgia who, sort of are the first examples of something that had been forewarned for many years, which is, if Roe were to be overturned, yes, people will face all kinds of complications, but sort of the worst case scenario, women will die, patients will die. We now have those examples in these two cases. And, we, as you mentioned, Dr. Pariai, we have a vice president and, a presidential nominee talking about these cases on a national stage. And actually, Dr. Palacios, I was hoping you could talk with you. You could start and talk a little about to have these stories, like the power of hearing those real women's stories and how the power of story may shift the conversation around this.
Yes. Okay, can you hear me? Okay, great. Yes, the narrative, right, around abortion is that only bad women do it. It's a bad circumstance. They're poor. They're usually brown or black. Something's wrong with them. They're unfit. And that's why they're doing it. It's shameful, there's blame, there's judgment. And that's not the case, because I assure you that wealthy women in our country, even though there will be, there are abortion bans, they will still receive and seek abortions. So yes, the whole narrative shift of helping people understand, and I would say take it a step further, that something that I have shared is a general observation of over 16 years as a nurse midwife, but also lived experience in the maternal child field for 20 plus years. But that is that our country is so far away from understanding what women's health is, or what pregnancy is, or childbirth is. The fact that ectopic pregnancy is an emergency, and that people who don't have a uterus or are not childbearing did not understand that, and made decisions to ban abortions, or a provider who is afraid to intervene in someone's life as a life-saving measure, demonstrates just where we are as a country, as a nation, culturally, that we are so far away from other developed countries that have better outcomes than we do, because they have a different frame and reference and attitude towards women and childbearing people.
Yeah, thank you. Dr. Robinson, maybe you can talk about, these first two cases are Black women. Black women are so disproportionately impacted by maternal mortality, sort of as a, we've almost seemingly in some ways accepted that as like a fact of life here in the United States. You talk about, how abortion bans may exacerbate that in states that have already have such poor maternal health outcomes, especially for Black women.
I can go ahead and tie it into your previous question in terms of like looking at, sometimes when we have this perspective and it's not directly hitting home, we understand it in theory, but we don't really actually understand it until it's in our face. The one interesting thing about public health, and I always say, you may ignore a community's lack of resources, inequity today, but it's a domino effect. So whatever you don't resolve today, it will eventually hit home tomorrow, not figuratively speaking. And so I think what's very important is for us to not just look at it as that, oh, those people, that individual case, this is all of our issue. Reproductive health, I can't remember which one of my co-panelists had it on the screen, but reproductive health is public health, right? And I think we just need to make sure that we prioritize the needs of everyone. I mentioned in my presentation that maternal deaths in this country, in an innovative country like the United States, 80% of maternal deaths are preventable. That is a lot, and it's actually unexcusable for a country like ours. So whenever you see that sort of problem taking place, whatever it is, we're talking about maternal health today, but whenever you see that inequity, you always need to ask yourself, who is benefiting from this problem and who's suffering from this problem? And that's going to give you a large insight in terms of the strategies to go about in resolving it.
Say a little bit more about that. From what you see, like what are the strategies that perhaps states or federally we're choosing not to do, that could improve this?
Prioritizing certain people's voices over others. That's really what it comes down to. We have enough resources in this country. We have a sickness of greed. Unfortunately, in this country, even though we've moved over to a pay-for-performance sort of infrastructure in medical care, we very much so focus on fee-for-service. And so what that means is for every service that is delivered, then there's a cost that's associated with it. But just because a person may receive a lot of costs when it comes to their services, it doesn't necessarily mean that they are guaranteed the best outcome. So I think really understanding what equity is, and even just having a mind frame to be open to receiving it, and then understanding how we're all interconnected. We look at maternal health as like this silo, but maternal health is interconnected with how a person views their religion and how a person eats and where they are demographically located. So really just understanding how we're all connected and taking ourselves outside of ourselves of being greedy, and then really understanding and having a different framework to where all of us are included. Because there's room for all of us to succeed and have a healthy life. We've seen it done in our peer nation. So if they can do it, we can do it too.
Dr. Apadiai, we saw, with these two women in Georgia, both of their cases involved, obtaining and taking abortion medication, or, that's what we're hearing so far as these stories sort of unfold. Obviously, we're almost immediately seeing, folks on the other side, right, blaming the abortion medication itself. Can you talk a little bit about, from your perspective, how this is playing out?
Yeah, I mean, I think that was my worry when I first read the headlines. That's why the article was so well done, because it really showed the complexity. The people so we know that about 5%, 3 to 5% of people who take abortion pills will need an additional procedure to complete the abortion. And so that is expected, and the antis often take that number, that expected outcome as abortion is so dangerous, right? They always take it to that extreme. And people do, about 4 to 7% of people, after they take medication abortion, they go to an emergency room because they're worried about their symptoms. They don't know if this amount of bleeding. No, people don't talk about medication abortion or what's it supposed to be like. So they're worried, they're scared. And especially if they're doing it alone, they're more likely to seek care. In these two cases, unfortunately, they didn't. Well, I think in one of them, they sought care, they didn't want to do anything. And then in the other case, I believe she did not seek care because she was afraid of being criminalized, prosecuted for taking the pills. So it is really concerning, that people are not seeking basic health care, and even when they do, they're not receiving the basic health care. And so that should be very clear, and it is worrisome. The antis are blaming the abortion pills themselves and not the healthcare system and not the legal system.
Right. Do you worry about, I assume you worry frequently about future restrictions on these medications, but do you think about how sort of this narrative forms around these sort of things?
Yes, I'm obsessed with that.
Yeah. Do you ever think about that?
Yeah, no. So they come out with articles, with research that totally conflates the findings. They exaggerate the outcomes. And so I think it's important that we talk about, people needing additional care when they take these pills. It's really important that we talk about it. And yeah, I think they're going to keep coming after abortion pills because they expand access. So they're so powerful in that way. And they're going to keep being creative and come up with new ways to restrict access to these medications.
Dr. Srinivasa, these stories obviously came out of Georgia. So many of the stories we hear are coming out of Texas, where I am, these states that have banned abortion. But as you talked about in your presentation, there are barriers to accessing reproductive care, even in states that have done a lot to protect abortion access. Can you talk a little bit about what are those challenges for gender diverse populations? What are the different barriers that groups face?
Yeah. So as I talked about, transgender, gender diverse patients have experienced oftentimes kind of significant trauma and experience a lot of gaps in health insurance coverage and therefore gaps in care. And for me in particular, it feels really frustrating if you can have a patient that feels at home somewhere for care, somewhere like Fenway, where this is what we do. 15% of our patients identify as trans or gender diverse. And then we say, we will take care of you from head to toe. Literally, we have podiatry. But this one thing we cannot do. And what ends up happening kind of over years and years and years is that there's kind of just chaos and confusion that gets perpetuated, and people don't even want to touch the topic of abortion care because of risk of loss of federal funding. And then when you ask questions like, what are Hyde Amendment exceptions? Does anyone even know what those are? People don't even want to answer that question. So it just kind of perpetuates and perpetuates. And so it's kind of just this really interesting paradox where we take care of this kind of marginalized patient population. We try to embrace them and do this wraparound care, except for this one thing. And so there's still kind of barriers. And this is all federally qualified health centers, so people that are trained to provide this care, and even in kind of in advanced gestational ages, our hands are somewhat tied because we're risking federal funding to our health centers, which often serve kind of marginalized patient population. So it's kind of this perpetual cycle that's really challenging to kind of come out of. And as we were just kind of talking, one of the things that I was just thinking about is, appealing to the population's kind of desire to positively impact public health is tricky, because I think the pandemic has shown us that that's not always a priority in this country. And so I was just kind of brainstorming while everyone was talking, with like, how can we appeal to people? Do we have to build a business case around like the multi-generational impact of maternal mortality? Because it's not just that generation that's impacted, right? It's like generations and generations, and there's a huge fiscal impact and economic impact, et cetera. So I'm just kind of thinking about how can we build this case in a different way to appeal to what seems to be the priorities of people in this country right now.
Yeah, absolutely. I think these stories that we've heard the last, week or so from ProPublica have really shifted the conversation. As I said, Kamala Harris is talking about this issue, and there are also, as we said, like stories of Black women. So far, I mean, especially I report on this in Texas, and we've heard so much from primarily wealthy white women who have shared their stories, and very impactful stories of having to leave the state for care. These like near misses. I mean, stories that do move the needle. Kate Cox, Amanda Zorowski. But then, Dr. Palacios, I think about what you said about, Native women aren't even counted in the data sometimes, right? I mean, how do you see efforts to sort of widen the story of who we are hearing from in this? Like, what would you like to see on that front in terms of the stories that are being told about the post-Dobbs era?
So there are small pockets where this work is happening, right? Like in Seattle, the Pacific, the North Pacific West Coast, right? That I can think of at least like a Native story that's happening in the Pacific, in Seattle, where you have a capacity and you have the resources that can support these stories. It would be really challenging to have these stories out of North Dakota, South Dakota, Nebraska, right? I mean, it would have to come from places that have the support and resources. So putting, inviting community organizations that are already working with communities and families is going to be really important into this work. And there's also that issue of trust, because of distrust and mistrust in being abused over time, that having someone's story is also very vulnerable. So when a national public view or gaze is given to, maybe in Seattle or a smaller rural community, that person is exposed to so much. So you have to have the infrastructure in place to help support. And unfortunately, that will probably only likely be coming from Minneapolis, Seattle, Albuquerque, Phoenix, and these larger cities with some resources. And a part of that is also like the diversity, the breadth of diversity in those areas as well is really important to that experience. So it will take time. It will take support. It will take strength from the storytellers, the bearers of these stories, to come forward. And part of the story reframing and shifting the narrative is to replace everyone's image in their mind of what abortion means. I'm not talking about everyone here in this room, but in our nation, right? It's going to take replacement stories and time again and exposure, and that hopefully will aid in reforming and shaping that abortion is healthcare. It's essential. It's healthcare as well.
I mean, I think many of the, I know many Native American communities, and many rural communities largely just were not served by abortion, even when Roe v. Wade was the law of the land. I mean, and are facing pretty significant maternal health challenges that, long predated that. How are you sort of seeing the focus on abortion impacting that, like attention on this maternal health issue more generally? Is it moving the needle at all?
Again, it is really difficult because while in some circles, yes, it is allowing space for those voices to come through and people to share their stories in very supportive environments. In areas that it's really needed, right, in tribal communities and in tribal politics, you have to put that in context of hundreds of years of being inundated into a very Christian view of the world, which many Native communities have been.
So you are battling also this extra layer of internalized racism along with heavily forced Christian values and views that have displaced a lot of, not every, but a lot of our traditional spiritual practices and how we walk in the world. So there's a lot of layers that have to be addressed, which in some communities they're just not existent right now. And it's very covert when we're talking about these. And it's very, again, like in some states where you can't say racism in their state reports, like they avoid saying these, we're code switching again. It's back like in the 90s. The same thing's happening in these communities as well.
Yes, yeah, absolutely. Dr. Robinson, can you talk a little bit about, I mean, you've worked with the Massachusetts state legislature, Massachusetts state government on these issues of maternal mortality. I mean, at the state level, like what can move the needle on this? What is impactful?
Well, I think we're already seeing that. So, you have neighborhood birth centers. So like really looking at out of hospital settings, supporting integration amongst providers. So not just OB-GYNs, but also looking to see how they can better, or how everyone who is considered a provider, how can they support the need of the patient individually? Because not only does it help the provider to understand a different framework or a different ideology for providing for the patient, but it also supports resolving inequity. When it comes to health, as you all know, health is not a one cure-all sort of thing, but really looking at an individual and looking where that individual comes from, their needs, how they have been trained, recognizing our own biases as providers. You had mentioned trust. Trust is very important, and it's not just a patient to provider relationship, but it's providers amongst each other need to trust each other in terms of delivering patient care. So really looking at our individual selves, being confident in what we bring to the table, but also being open-minded to where whatever we lack as providers, someone else can also support us in providing for our patients. And so we're seeing that. We're seeing that with more support of doulas, lactation specialists, screening for mental health. A lot of times we don't talk about maternal mental health, but as we've talked about today, abortion can take a psychological toll. So really looking at how all of those intricacies work together, and then starting somewhere very basic and then just being consistent with that care. So those are my thoughts on that.
Yeah, thank you. Dr. Padiai, I wonder, Massachusetts as an example of a state that has passed one of these shield laws, you talk a little bit about how those a little bit more about how those laws are sort of contributing to some of the data you showed about, we're actually seeing more abortions in some ways, just a very different map than it was a couple years ago.
Yeah, the shield laws really have contributed to access. The thing is that people living in states with bans need to know that these services are available. And many people still don't know that telehealth is a thing yet, even in states where abortion is broadly legal. And so, and how do you get one? How do you get, normally I have a slide, I didn't include it today, but Plan C pills everybody should know the website Plan C pills, because that is kind of a directory of, you could enter in your state and you can look at all of your choices among the shield law providers. There are also community networks that provide access to medication abortion outside of the healthcare system. So some people prefer that, going through a community network or someone within their community to get their abortion pills. And so there's an array of choices there that people can access.
Yeah, great. And we are shortly going to open it up to questions, so start thinking about that. But before we do, we are talking about, we're here sort of on the precipice of a presidential election. I wonder if each of you could talk a little bit about, in your ideal world, if a presidential administration really wanted to take this issue, not just of abortion, but of reproductive health care more broadly, really take that on. Like, what is one thing you would like to see a future presidential administration sort of bring to the forefront that has not been discussed so much? Do you want to start?
Sure.
You've got your hand
Yeah,
up.
no.
Yeah.
The Hyde Amendment, it came up today. I mean, if there was anything, this is an amendment that prevents federal funding to cover abortion. So that is why states that allow Medicaid for abortion have to use their own state funds. The Hyde Amendment is also why Fenway Health cannot provide abortions, because they do receive federal funding. And so even if there, I don't know if there are creative ways, that might be a question for you, if there are creative ways to separate funding streams. But it really has reverberations throughout our entire abortion care. You know, I think even NIH for a time was saying they couldn't cover research on abortion. And now, I mean, that is one of the things since Dobbs, NIH is now paying attention to abortion and is realizing, hey, the Hyde doesn't impact us. You can still do research as long as it's not paying for people's abortions. And so, yeah, that's like number one on my list.
Dr. Srinivasa?
Yeah. So I would agree, given I'm actively kind of working on the workarounds. And I think that as a provider is really frustrating, because I think it's just so hard to do the right thing. And I think that's the trouble here, like that I find just when I'm kind of communicating with patients, like, why is it so challenging to do the right thing for this person? The other thing that I would add is just kind of taking a look at biases within our own healthcare system. There are so many biases on every single level of the healthcare system, like even diagnosis codes for abortion, like for a long time included elective abortion. Like that shouldn't even be part of the language. It really shouldn't even be part of the conversation, I think. And I think that even amongst us OBGYNs, there's only some that will provide this level of care. Like, how does that feel for someone who has been seeing this provider for many, many years, and they come to them for this one thing, and then they can't get that care because that person doesn't do that type of care? Like, I think there's a lot of bias that's infused in every single layer of our healthcare system that we need to kind of really look at unraveling. So,
I agree with everything as well. And I would, to be different, I would say expanding access in terms of providers that can do this. We forget that OBGYNs are not the only people that can do these services. And I will represent for UCSF as a place of my alma mater as well, because we have a lot of Boston University, showing here. But a dear colleague and classmate, Monica McLemore, and I attended school together, and she is like the #1 voice in terms of advanced practice nurses, allied health professionals be involved in procedures and in with access to abortion care. So I would lift up the fact that it's outside of a doctor's hands. It can also be in a nurse practitioner, physician assistant. And so we can expand. We live in maternity care deserts. Like almost the United States is an entirely one big maternity care desert, or reproductive health desert, we should start maybe calling it. But we can shore that up by increasing the number of physician assistants, nurse practitioners, nurses. We don't have to just put money into physicians. They're not the end all be all as they may think they are.
I agree with what everyone on this panel has said, but also to be different, and also to add on to what you said. We've talked a lot about abortion rights today, but I want us to, really just think about abortion rights are part of reproductive rights, but they're not all of reproductive rights. And so I think that what I would like to see as whoever leads in this, leads us as a country the rest of the way, they really understand and appreciate reproductive rights, the right to be heard, the right to be seen, the right to have a say-so in terms of the type of care that they want to be delivered to them. All of this I think would be very important. You know, when you look at our country as a whole, we're very individualistic, we're very bold, we're very confident, but sometimes in that confidence and that boldness, there needs to be a little bit of humility in there somewhere in terms of, you know, us providing for different people that we may come in contact with, people we work with, and also people that we provide care for.
Great, thank you. So we're going to open up to questions. I think there is a microphone moving around. Just they're getting the microphone. While we do that, a reminder that questions end in a question mark, and we ask you to keep them pretty short and succinct if you can. We've got someone up front. Sorry, a young woman right here.
Hello, Khadija Silver, they, them. I'm a supervising civil rights health equity attorney at Lawyers for Good Government and also a proud BU Law and BU SPH alum. Very grateful to be here and in the space of such amazing leaders in this work. I'm gonna say the thing because that's my job. We live in a world where board members at hospitals get to dictate care. They also get to dictate who runs for office, who gains office, and how that funding is distributed into which communities. While I love the Hyde Amendment idea, I also am curious, how much does hospital financing and the power dynamics at play among largely white men impact how much you all can do, and what do you think are the counter levers that we need to be using given these norms and realities?
Anyone want to tackle that?
I would.
Anyone have a job not dependent on
I am not going to attack all of it, so I'm just going to take one little piece
please.
and please help out. But I would also say that that the production of knowledge in terms of our reproduction care, right? If you look at the names of the people, it is a handful of men in our country that are in charge of all the teams that produce the knowledge about reproductive care in our country. So I would say what we have to do is we have to fund people who have a contrary lived experience, and that begins with women of color. Mm-hmm. So that's what I'm saying. Also, we have to look at their generations of children and grandchildren, because we have to educate. We may not be able to educate them or change their minds, right? But we can work on, which is what some people in our country are really afraid of, education and diversity, but we can work on the next generation, and we definitely can do that.
I think also hospitals and healthcare organizations, community health centers, they are businesses, which is tricky. But I think, to echo kind of some of the points that you have made, patient voices are really powerful to kind of counteract inertia. So I think that when it comes to like hospital level change and kind of community health center change, all it takes is one safety event or one patient voice or one complaint before people really start kind of opening their eyes and their ears. And we never want it to get to that place, but I think that for people to continue to advocate for themselves, I think those voices are really instrumental to kind of counteract longstanding inertia.
Dr. Robinson, did you have something to add? No, you don't have to. That's fine. That's fine. I thought you did, but yeah. Yes, did we have a question over here? Yes.
Yeah, two questions. First, in response to the more recent comments, the blame really doesn't belong with white men. I'm in menopause years, beyond my childbearing, and I want you to know it was the older white men who understood, not one single female health provider, not one. So I was grateful for the elder white man who understood what I was going through and not the women who did not. Maybe they're falling apart, but in medical school, you're not teaching women doctors how to deal with women when they get older. The other thing is on the Hyde Amendment, unfortunately, that's something that we've lived with for a very long time and came out of the liberal state of Illinois. So, well, disappointed. I don't know how much hope there is for that. but can you refer, since there is money from Massachusetts out of Fenway, can you refer people to healthcare providers, especially with what Governor Healy's been doing to get proper care here?
We can refer, absolutely.
Thank you for sharing that personal experience. Oh, did you have something to add? Please.
I wanted to go ahead and respond to your first comment. I've been in positions to where the person that you would think that would provide the best care, oftentimes, or in some situations that they're not. I think in addition to creating a culturally diverse workforce that responds to the needs of patients, also checking that person's health integrity, not just who they are. A lot of times what I'm saying, as we become diverse in our provision of care, the understanding is, okay, we have Black patients, okay, you're Black, we're gonna assign you those Black patients, which is not necessarily getting to the root issue, because if there's no relationship that's shared between the provider and patient, regardless of race, then there's still work to be done and no work has taken place. So I think when it comes to us being productive so that we don't repeat the same cycle, I think that we need to check the integrity of health and overall wellness in terms of how does this person interact with their patients. I think that we would have a more key component and a better resolution to making sure that there's a patient-provider fit.
Yeah, thank you for that. Yes. Yes, we've got a young woman here. Did you have your?
Hi, my name is Mira Donaldson, a recent graduate of Spelman College and a graduate of journalism at BU. And my question for you guys is, we're in Massachusetts, a liberal state, all this, we're kind of sort of in like an echo chamber where, we're not scared to talk about this stuff. And we have a lot of laws that are enacted that we support that are for reproductive justice. But my curiosity is where you feel as if the liberal state lies in the role of advocating for these things.
Advocating for which states?
My question is, where do you feel the liberal state lies in the role of like advocating for reproductive justice systemically?
Like how can blue states help move the needle sort of on the national level, even while red states move it in the other direction? Yeah. I think, Dr. Putty, I think.
I can jump in. I think it's important that we keep talking about abortion bans. I think it's so easy to forget, those are those 14 states in the South, Southeast, and, it's not where, I think like the money is in the Northeast and on the West, and, there's so much, like, it would be very easy to forget and to say, oh, well, those states, they decided it, it's in the states will decide. It's not the state. I mean, it's people with the capacity of pregnancy in those states that are affected most. So I think having symposiums like this, and just I think journalists, I talk about journalists a lot, I think it's so important. They're doing really great work by shining a light on these cases, on the outcomes, on what's happening, on the trends. I mean, for the We Count, we release a report every quarter. And I think it's really great because it provides people with data. It reminds people of what's happening around the country. It's so easy to lose sight of what's happening in other states. And so, and the journalists are covering it, which I'm excited about, but they still think it's newsworthy. Every 3 or 4 months, and they find a different angle to talk about the trends. So I think that's one thing that blue states can do. I'll add one more thing, since we're in an echo chamber. I think there's more that blue states can do. So there's only a handful of third trimester abortion providers. And there's a lot of talk in blue states like mine, California, and like Massachusetts, but people who need third trimester abortion care, it is so hard for them to get this care. It's hard for them to get it covered, to get it paid for. And so, why do people need abortions in the third trimester. That's usually the question that comes up. We shouldn't be asking about people's reasons, but it's for the most of the time, it comes down to two reasons. One is they learned something new about the pregnancy in the third trimester. Sometimes it's that they're pregnant altogether. And then the second reason is because of barriers, because of abortion bans, because of the inability to pay. And by the time they collect the funding, they're later in pregnancy, and then they have to collect more funding, and then they have to plan a trip, and then they have to find childcare, and then they have to schedule time off of work. And so that is the second reason, barriers to abortion care. And so we need more legal avenues for third trimester care, and more funding for third trimester care, and more providers. There aren't enough providers. And so, yeah.
I think like creating pipelines for trainees too is really important, because less and less people are getting trained in providing this type of care. So for example, LSU residents come and they do rotations here in Boston to learn about delivery of abortion care. And we partner with them at Fenway to teach them about trans and gender diverse patient care and gender affirming care, because they just can't get that in Louisiana. So I think kind of making that having less friction associated with those pipelines is really important, so that we can continue to train people to continue to provide that care, and expanding it to the lifespan. So like, I think we've talked a lot about the young patient population, but I think extending that to perimenopause, menopause, all of that is really important.
And I'd like to add something as well. I'm going to take it from a professional but also personal perspective. So I'm an assistant professor here in Boston. However, you can tell by my dialect, I'm not from Boston. I spent about 9 years in Texas, and before that, I was born and raised in Mississippi. So I understand what you mean in terms of, people coming together, and basically just people even coming to this symposium just lets you know that they tend to have a different frame of thinking that, say, for instance, many people, not all, but many people from the South. With that being said, I think we need to look at the framework of what was going on during the civil rights movement in this country. If you look at a lot of progress that was made in the South, it was made in the South because of local people interacting with each other, but it was a lot of people from up north that created the very pipeline or the pathway that you're talking about. So I really think that going back in history, looking at that framework to see what is it that you all need, what resources do we have to fulfill that need? Because now we're not just talking in theory, but we're actually looking at what do we have and how can we move one step forward. And you'll notice that if you do put one foot in front of the other, in front of the other, in front of the other, progress will be made along the way.
I'll also just add, from the perspective from Texas, right? I think you're asking a very, very good question. There's also I always say Texas, has 10% of the women of reproductive age in the country, right? Abortion is overwhelmingly positive or overwhelmingly supported by people who live in Texas. These laws are not necessarily representative of what voters say in polls, at least, that they want. And also, there's a lot of community organizing happening around that. There is a lot happening on the ground in these, red states that have banned abortion, that maybe, what's happening under the surface doesn't always look like necessarily what elected leaders are doing. So I think there's a lot happening, a lot that blue states can learn from what's happening on the ground in red states, even if, their state governments aren't necessarily on board with all of that. Yes. Oh,
Hi.
Yeah.
Hi, Asia Watson. I'm here with Planned Parenthood League of Massachusetts. And this has been alluded to a little bit, but on the topic of Black maternal health outcomes, as someone who has a 2.5-year-old, and I just went through this experience personally, what does it look like? I've heard the term culturally diversifying our workforce. What does that actually look like? And then how could that over time change those outcomes? I think, in my experience living in and growing up in a global healthcare capital of the world, I feel like, I just thought it would be easier to find a provider. But to your point, Vanessa, it's not just finding a provider who looks like you. It's the facility that you're in. It's, do you even trust that person, even though they look like you? Like, you may not trust them to take care of you. So I think that's the baseline of, finding a provider that can relate to my experience. But sometimes, not just in maternal health, but in all healthcare, you feel like as a Black person, you're sort of settling for the one or two options that are available to you. So what does actually diversifying the workforce look like in the medical field, and how does that play in, how could that play into Black maternal health outcomes?
I would say including everyone who has a part in providing care for that Black birthing mother. So for instance, a person who's a mother who is competent in their provision of care, a person who is racially sound. I say racially sound because you'd be surprised, but not all Black people like other Black people, right? So racially sound in terms of how comfortable they are with delivering care. And also for a patient, I would say advocating for themselves. OB-GYNs don't come for me because I know they're like, some OB-GYNs are like, okay, don't make our work harder for us. However, there is a bidirectional relationship that needs to take place. As a new mom myself, so I recently gave birth to my 3-month-old. I asked my provider questions every time I went in and every time I was paying attention to how she would respond to my questions. And it wasn't necessarily a test. These were genuine questions that I wanted to know. But every time, shout out to my doctor, Dr. Katie Doof, she made me feel safe. Not just because she was a person who had my same skin color, but she was competent in what she did. She was kind to me. So I think in terms of diversity, it's such a broad term, but it can have so many different meanings depending on the patient and what they need. Some patients, for example, they need someone that looks like them. Some other patients, they need someone who shares their same experience. Some people are just emotionally sensitive, so they need providers that are also sensitive to their needs in that regard. So when we say diverse, I think, and not to put the question back on you, but as a patient, whatever is your priority of needs, seek out that person that can fulfill those needs, whatever they may look like, whatever gender they are. And if you feel safe with that person, then that's a provider that may be for you.
Thank you. We're going to do one more question from the Q&A or on the Zoom.
Can people hear me? Okay. So this question is coming from the Zoom chat. Could you speak to the impact that laws in which a minor must have a parent's permission in order to proceed with an abortion have on reproductive health? Big one for the last one, but if anyone has thoughts on that.
Anyone have thoughts on judicial bypass?
We also got a few questions just about how to get involved more generally. Folks who helped to legalize abortion in the 70s, folks who aren't able to have children, just, I guess, getting involved in reproductive health.
Yeah, I think, I mean, I'll just say, I'd be curious to know, I don't know if any of you know how many states that had these laws that require parental permission. Many, I know Texas had that law, abortion is now just banned. So it's like, I'm curious how many of those laws are still sort of in effect and how much they overlap with the states that just banned abortion.
Yeah, I think there is a lot of overlap, but surprisingly, there's also not a lot of overlap. I mean, didn't Massachusetts just have, and it just removed the law, right?
Some of them have notification and some of them have consent.
Okay.
So those are
Yeah, and maybe so Massachusetts still has a notification or consent? Wow, for under 16. So, yeah.
Right. So requires a judge.
So that's something that Massachusetts could work on, eliminating, eliminating that requirement, because it leads to delays, right? Having to go through the judicial bypass process and requiring parental consent. There is research that sometimes it actually causes harm to the young person because their parent does not approve, and if they don't, so there's a lot of, it creates barriers and creates delays in accessing healthcare.
Just as we wrap up, why don't we do sort of rapid fire, each of you, some way that you think if people want to get involved on this issue, that you would encourage them, 6 weeks out from a national election, perhaps?
Okay, so very quickly.
How do you think?
Seek out wherever you are locally, seek out whatever maternal resources are there, and volunteer. Volunteer in whatever way you can, whether it's passing out pamphlets. Do they do that anymore? Well, if they do that in your local community, in whatever way you can push this message forward, just go with it. You don't necessarily have to be the founding director of something. You can start small. And actually, I've found when you start small and you're consistent, it develops you along the way for when you are called to a bigger purpose.
And I would add that as you're doing that, as you're volunteering at these places, that I intentionally created this presentation to try to reach people who didn't have an opinion or who could be swayed. Because I would advocate for you to try to align your values and find shared common ground with the people who you're speaking to and start there as a place of discussion.
I think educating yourself, I think some people have more comfort in a spotlight or with advocacy than others. And I think that a lot of people just don't even know about some of these disparities, or that so many Black women are suffering kind of at greater rates. And people don't, that wasn't part of my medical school education here at BU or my training here at BMC. And it wasn't it was a long time ago, but it wasn't that long ago. And so I think educating yourself is kind of step one.
I would say first vote and make sure everyone around you votes. Give people rides, hopefully, or encourage them to do absentee. And then second, donate to abortion funds. The funds are really running out of resources. So these are funds that are set up to provide patients looking for an abortion to help fund them, or also helps people travel to reach an abortion clinic. And they dry up in the middle of the month. They have to shut down their phone lines and say, we're out of money this month. And that's another reason for delays, and people have to wait till the next month to access abortion funds. So you can donate.
Great, thank you all. Let's give a round of applause to our panelists.
First of all, thank you. Please join me in also thanking our moderator. Thank you. In our academic community, we talk often that our job is twofold. Number one is to generate the data science scholarship on which the foundations of decision-making happen. And number two is to make the argument that convinces people, that translates the science so that action can happen. And I thought this panel was a wonderful example of both of those, of both showing the data and the science, but also showing and teaching us how we can actually make those arguments. So thank you again to the panelists for a really terrific panel. We're going to stop for lunch. This is it's a highly efficient and engaged morning. So lunch will be exactly 18 minutes, and we'll start right back. We'll start right back at 12:15. Thank you, everybody.
It is so nice to be here with you all today. And I want to thank this morning's panel for setting the stage, and Boston University for having me here today. I was actually really excited, not because I went to Boston University, because I love Dr. Martin Luther King, and he went to Boston University. So, I thought about all of those, the ways I was thinking about how he might have traveled here and what he learned and how it applied to his work as a movement leader. So let me start by saying that I deeply believe that abortion care is essential health care, and more importantly, it is a tenet connected to a basic human right. Unfortunately, the ways that people, especially those relegated to the margins, experience these essential rights are increasingly based on the political whims and social beliefs of others. We know this to be true when you watch television, scroll through social media, or read the newspaper. In fact, Angela Davis once opined that rights are for those who have privilege and duties are for those who are poor. Yet we know that regardless of class, racial background, or national origin, the ability to make decisions about one's own body is the cornerstone of what it means to have agency. An agency is an articulation of self-determination, especially in this political moment and in this space. As I think about the brave stories that have been shared by the center's clients, and earlier today, people talked about them on the panels and how they've been able to influence the political conversation, I am both proud and cautious because there is so much more to be done. I want to break up my remarks a little bit, and I will share a broad overview of the reproductive landscape and then pivot a bit to specifically discuss the impact of bans on pregnant people because I want to lift up the experiences of Amber Thurman and Candy Miller. Okay, the technical part. The Center for Reproductive Rights is a nonpartisan organization, so none of what I am sharing is intended as a political position, and please view my comments as informational only. Thank you. That's my commercial. Since 1992, the Center for Reproductive Rights has fought here and abroad to advance reproductive autonomy. Since the Dobbs decision, the work of the center, as well as other partners, has become increasingly more important, particularly because abortion care access is a central focus of this year's election cycle. Both presidential candidates have expressed their perspectives on how this care should be meted out. And while who sits in the Oval Office is important, since Dobbs, the momentum underway in the state deserves to be lifted up. To date, there are a record 10 states that have ballot initiatives meant to decide whether to enshrine abortion rights in their state constitutions. That will be decided in November. And there is clearly, this is clearly a purple issue because these ballot measures are both on ballots in blue states as well as in purple states. So this time I'm gonna really look down because I want to focus and run through very quickly the ballot initiatives that I wanted to lift up. Arizona, considered a swing state, requires a 50% threshold to pass, where Florida requires a 60% threshold to pass. Other states, including Maryland and Missouri, require a 50% threshold, and the ballot question centers on reproductive freedom in Maryland and in Missouri, while Nebraska's ballot has 2 questions related to viability and the other banning abortion after the first trimester. As it was mentioned earlier today, there are 22 states that ban or restrict abortion. So successful ballot initiatives would be critical in states where the bans would be lifted, namely Arizona, South Dakota, Nebraska, Missouri, and Florida. Because of their proximity to states where there are current bans or burdensome restrictions, this will be an opportunity to create some sort of a gateway. For example, if the ballot initiative is successful in Florida, then it would unlock critical access in the southern region for surrounding states such as Georgia, Alabama, and Mississippi. Ballot initiatives are not a perfect solution, but they have been important in illustrating how most people deeply believe in freedom and have a desire to make decisions about their lives. As Ella Baker once commanded, we who believe in freedom cannot rest, and across our country, folks are not resting, they are fighting for it, including a federal effort to rebuild rights lost after Roe fell by coming together and pushing for federal legislation where rights are concretized and more expansive. Proudly, the center alongside coalition partners have committed to a 10-year campaign to build support for reproductive freedom and autonomy. This includes ending the Hyde Amendment, protecting the right to contraception, access to IVF, and expansive access to abortion care. I know it was mentioned earlier this morning about the SHIELD laws. The center has proudly worked on SHIELD laws, including supporting the SHIELD law in the state of Massachusetts, or the Commonwealth of Massachusetts, or do y'all call yourself a state? Sometimes it goes back and forth. While there's been a push to enshrine protections in the state constitution and the federal efforts following Dobbs, states have stepped up and developed SHIELD laws. 18 states and the District of Columbia have passed interstate SHIELD laws, which are designed to protect abortion care providers, helpers, and patients' medical records in states where medical records in situations where a patient from a state where abortion is illegal obtains care from a provider in a state where abortion care is legal. Some states have also included protections for transgender healthcare providers in their interstate SHIELD laws. The shield laws have been critically important, and there is more to come on those because they have not been tested as of yet. And also the limitations of the shield law was mentioned earlier in terms of the burden of traveling to those states to get to receive reproductive health care services. At the top of my remarks, I mentioned the courageous efforts of our individual clients to share their most personal stories. And to your point, to be vulnerable in that space requires a lot of support and ongoing attention to how those stories are being used. And so I wanted to thank you all for lifting up the impact of the bans and the focus on it during this morning's panel. The Supreme Court's decision in Dobbs and the state abortion bans that follow have placed unreasonable burdens and constraints on essential health care access and erodes reproductive autonomy. Such burdens often fall on people living in undersupported communities across our country. Recent reports highlight the specific impact on Black women, as many live in states where abortion bans have been enacted. And I would just highlight that the restrictions that we're talking about, some of those existed before Dobbs fell. And I think that that's important because when you see it in the media, and it's not anything, a slight toward the media, most people may have the impression that this was as a result of Dobbs, as opposed to something that the center and many others have been fighting for a very long time to make sure that as much as possible care was provided across the country. And for Black women without financial resources and social support such as child care, the very basic right to access essential care has been out of reach for a very long time. Last spring, the center partnered with Lift Louisiana, Physicians for Human Rights, and Reproductive Health Impact to produce a report titled Criminalized Care, How Louisiana's Abortion Bans Endanger Patients and Clinicians, to highlight the impact of bans on pregnant people. Pregnant people who seek an abortion may face legal risk of being criminalized for doing so. Research has found that from 2000 to 2020, 61 people were criminally investigated or arrested for terminating their pregnancy or helping another person to do so. Most recently, Reproductive Justice produced a report that indicated that the number of people subject to investigation continues to rise. And for some women, these bans have literally resulted in death. Say Their Names, a familiar slogan that is used to describe state action that has resulted in the deaths of Black women, has been in the news since, much like Black Lives Matter. We have called out the names of Breonna Taylor, Sandra Bland, and most recently, Sonia Massey. And last week, for admittedly different reasons, some new names might be added to that long, painful list. ProPublica reported on the deaths of Amber Thurman and Candy Miller. Both deaths were linked to the impact of Georgia's 6-week abortion ban. Ms. Thurman died, and her son will be left without a mother because she couldn't obtain a legal abortion in her home state of Georgia. She was forced to wait and worry as her infection spread, and as doctors waited 20 hours before surgical intervention that was indicated for her circumstances. While rare, and I want to repeat that, while rare, Ms. Thurman's complications were entirely treatable with a common procedure. But instead, because of confusing, illogical, medically unsound, and dangerous bans, her doctors waited at least 20 hours before a surgical intervention. And by then, it was too late to save Ms. Thurman's life. As mentioned earlier, Candy Miller was a mother of 3, and her health was so fragile: lupus, diabetes, and hypertension. Doctors advised her against having another baby. When she found herself pregnant again, acutely aware of Georgia's ban, Ms. Miller died attempting to manage her own care and ended up dead. Her family shared with the coroner that Ms. Miller feared visiting a doctor due to Georgia's current legislation around abortion and pregnancy. Both deaths were preventable, yet predictable, especially for Black women who have had a long documented history of health disparities and lack of access. I reflected on remarks made by Ms. Thurman's mother about her daughter's death, and when she had a conversation with presidential candidate Harris, she did not want the public to know her pain. Or those made by Ms. Miller's sister, who said she was trying to terminate the pregnancy, not herself. Both assertions centered the deep pangs of loss and a reclamation of humanity. Last Sunday, if you're like me, I get up and I don't know why I do. I turn on MSNBC. Maybe I shouldn't do a commercial for them, but I do. I just turn it on. It's the background noise. But last Sunday on Velshi, I watched Yellowhammer Fund's Janice Fountain tearfully remind us all of how abortion bans would specifically harm Black women, especially those living in the South. Fountain's statement conjured up the tangled history and experiences of Black women and people in their limited access to general health care, but particularly reproductive health care. In my work, I spend a lot of time in the South, and I was always, and I think someone said it earlier, and this is just an aside, I was astounded when I talked to folks in Mississippi about the lack of basic health care that is available in general, let alone access to reproductive health care. So I would say, as we talk about the experiences of Ms. Thurman and Ms. Miller, please be cautious around how we tell their stories. Their harrowing outcomes should not be lifted up in service of a broader narrative. Instead, it's my hope, prayer, and deep wish that we use all of our energy and best thinking to honor their lives and center their families in our struggle to build a world where access to care is not dictated by geography. I want to leave you with a call to action that is in this political moment and during this time, we have an obligation to carry the burden of the moment. And yes, the load is heavy, but we can do it because we've been doing it. And paraphrasing one of my most favorite scholars and foremothers, Mary Church Terrell, who in 1916 told a group of Black women clustered in a sweltering church in Charleston, South Carolina, Mount Zion AME, those of us who are fortunate to have education must share it with the less fortunate. We must go into our communities and improve them. We must go into our nation and change it. Above all, we must organize ourselves and work together. Thank you.
Thank you. That was a terrific start to our second afternoon. I'm now pleased to introduce the moderator of our second session, Professor Nicole Huberfeld. Professor Huberfeld is the Edward R. Utley Professor of Health Law at the BU School of Law and the BU School of Public Health, and co-director of the BU Program in Reproductive Justice. Her research studies the intersection of health law and constitutional law, often focusing on federalism while studying the needs of vulnerable populations in health reform, Medicaid, and reproductive rights. In 2019, Professor Huberfeld won the Excellence in Teaching Award for Teaching at the Core at the School of Public Health here. In 2021, she was nominated for the Melton Teaching Award at BU Law. And in 2022 and 23, she was nominated for the Petty Teaching Award at BU Law. Professor Huberfeld, welcome.
It is an incredible honor and pleasure to be here with you today. As you just heard, I'm Nicole Huberfeld. I am having the pleasure of introducing our second panel. Thank you, Dean Galea, for that lovely introduction. And I also want to thank my BU PRJ co-directors, Linda McLean and Aziza Ahmed. BU PRJ is an interdisciplinary initiative that was launched on January 26th, 2023. We intended to have a celebration of the 50th anniversary of Roe v. Wade, and instead had to pivot when the Dobbs decision was leaked. And so instead, we held a multidisciplinary conference that was called After Roe and Dobbs, Seeking Reproductive Justice in the Next 50 Years. And at that conference, we launched our Program on Reproductive Justice initiative. The papers from that conference formed the basis for a symposium that we three guest edited called Seeking Reproductive Justice in the Next 50 Years. It includes more than 25 essays rooted in law, history, medicine, public health, public policy, and more, and I encourage you to find it. It's in volume 51 of the Journal of Law, Medicine, and Ethics. We have affiliates who are faculty all across BU, including not just law and public health, but also medicine, the College of Health and Rehabilitation Sciences, our business school, and women's gender and sexuality studies. We also sponsored a second conference in February of 2024 called Advancing Pregnant Persons' Right to Life, which we co-organized with the Center for Reproductive Rights, thank you, and with colleagues at Northeastern University's Center for Health Policy and Law, and that was published in the BU Law Review Online this past summer. We are also adding to our law curriculum with a new reproductive justice and rights track within the health law concentration. We helped the students here at the School of Public Health to start a Reproductive Justice Student Alliance, and we are supporting our students in finding paths into reproductive justice. Why do I mention all of this? Because our BU Law alum, Congresswoman Barbara Jordan, said our imperative is to define what is right and to do it. And that is what we are trying to do in BU PRJ and beyond. And I encourage you to think about that as we proceed with this panel focused on law and policy. So it is my great honor and privilege to introduce our incredible and very busy speakers for panel 2, The Future of Reproductive Law and Policy. It is a real powerhouse lineup. So first we'll hear from Gretchen Borschelt, the Vice President for Reproductive Rights and Health at the National Women's Law Center. She oversees NWLC's advocacy, policy, litigation, and education strategies to promote reproductive rights and access to comprehensive, affordable health care, including abortion and birth control. Prior to becoming VP, Gretchen served as Senior Counsel and Director of State Reproductive Health Policy at NWLC. And before joining NWLC, she worked at Physicians for Human Rights and was a Women's Law and Public Policy Fellow at the National Partnership for Women and Families. Next, we'll hear from Jocelyn Fry. Ms. Fry is president of the National Partnership for Women and Families, a policymaking and legal advocacy organization which works to advance healthcare, civil rights, economic justice, and racial equity in America. She is the first Black woman to head the National Partnership, which was founded in 1971. Prior to her current role, Jocelyn helped spearhead the Women's Initiative at the Center for American Progress, and before that, she served in the White House during the Obama administration. Third, we'll hear from Dr. Alina Selganikoff, Senior Vice President and Director of the Women's Health Policy Program at KFF. Her work focuses on health policies affecting women throughout their lifespan, with an emphasis on coverage and access challenges facing those who are underserved or marginalized. She has written and lectured extensively on the financing and access to health services for women on topics ranging from maternity care and reproductive health to long-term care. Over her career, she served on numerous federal, state, and nonprofit advisory committees focused on improving the quality of and access to health care for women. She's also an associate editor of the peer-reviewed journal Women's Health Issues. Finally, last but not least, we'll hear from Professor David Cohen, who is a professor of law at Drexel University Thomas Klein School of Law. David is the co-author of 3 books related to abortion. First, Living in the Crosshairs, The Untold Stories of Anti-Abortion Terrorism with Kristen Connon. Second, Obstacle Course, The Everyday Struggle to Get an Abortion in America with Carol Jaffe. And then also After Dobbs, How the Supreme Court Ended Roe, But Not Abortion with Carol Jaffe, which will be out in March with Beacon Press. His abortion-related work sheds light on the challenges faced by individuals seeking abortion access and the impact of anti-abortion violence. David previously served as a board member of the Women's Law Project and the Abortion Care Network and continues to represent Pennsylvania's abortion clinics in various litigation and policy matters. With deep gratitude to all of our very busy leaders in this field, I welcome Gretchen to start our remarks. Thank you.
Well, thank you so much, Professor Huberfeld, and thank you to the Boston University School of Public Health, School of Law, Planned Parenthood League of Massachusetts. It's really just a privilege to be here today with all of you and with my fellow panelists. So as you heard, I am Gretchen, I skipped ahead already. I'm Gretchen Borschelt. I'm the Vice President for Reproductive Rights at the National Women's Law Center. And for those of you who don't know the Law Center, there is a blurb here and a link to our website for more information. But the bottom line is that we are a multi-issue organization that uses the law in all of its forms to advance gender justice, especially for those who are pushed to the margins of society. So you're going to hear a lot more from my fellow panelists about abortion, digging into the laws and the challenges and the opportunities. What I thought I would do is actually talk a little bit about other reproductive health care and attacks on other reproductive health care. So I am going to do that a little bit, and I'm going to start with access to fertility care. I think most people have heard about attacks on fertility care and specifically on IVF because of what happened in Alabama when the Supreme Court there ruled that frozen embryos have the legal rights of children. And we saw providers in that state almost immediately halt IVF services there because of fear of prosecution and criminalization. What I want to say is that that result was an inevitable consequence of the Supreme Court overturning Roe versus Wade. It is part of a much larger effort in this country to establish fetal personhood in the law. And what fetal personhood is an effort to enshrine throughout our entire legal system, in all kinds of laws, the idea that a fetus is a person, is a child, is a human being, right? So we see it across tax law, in probate proceedings, in wrongful death laws. The theory is that if the anti-abortion movement can get this fetal personhood enshrined in our entire legal system, then when the Supreme Court is next posed the question, is a fetus a human being for purposes of our US Constitution, the court will have to say yes. They said no in Roe. So this was a question that was before them in Roe. They looked at it and they said no. So this is an effort to get the Supreme Court to change its mind. I just want to say that giving a fetus equal rights would fundamentally change our society completely, right? And it would mean that the government has not only the constitutional authority, but actually the obligation to protect a fetus's rights through oppressive and invasive control over anyone who could potentially become pregnant. Now, that is something that has been happening in this country. It's important to acknowledge. We have seen that happen in a lot of different ways, in particular in certain communities, indigenous people, poor people, certain communities of color. So it's not necessarily new, but if we give control in this way across the board, it will completely devastate us. I should also mention, someone mentioned the Pregnancy Justice report earlier, and that is an organization that tracks pregnancy criminalization. Here you see headlines from the report that they published of cases of pregnancy criminalization before Roe. They're releasing a new report, I think actually today, that has the data for the years after Roe so far. And there has been a drastic increase of prosecutors who use laws like child abuse laws and child endangerment laws to prosecute pregnant people for their behavior during pregnancy. And they especially target pregnant people of color and people who use drugs. And so, as I said, this has been happening, but were the court to recognize a fetus as a fetus as a person under our Constitution, it would give the government extra power and extra authority and extra reach and have an extraordinarily damaging effect on our laws and cultures. That would include outright bans on abortion and bans or restrictions on things like IVF, medical research, and birth control. And so I'm now going to segue over to attacks on birth control and dig a little bit more into that. And just as a level set reminder, when we're talking about birth control and the Dobbs decision is a reminder that in the Dobbs decision, the court essentially gave an invitation to go after birth control. And in fact, Justice Thomas, as you see in the quote here, said, I want to overturn the case Griswold that established the constitutional right to birth control. And so wanted to dig into what we have actually seen in terms of attacks on birth control since the Dobbs decision. One of the immediate things we saw in the immediate aftermath was abortion bans sweeping in birth control, right? Because some of the abortion bans in their definitions had confusing language. Vague language in the definition of abortion or in the definition of unborn child or person. You saw that already happening in the immediate aftermath. And so what we saw was confusion and chilling, much like we are seeing in the cases of emergency care now, where providers are uncertain whether or not an abortion ban would apply to their being able to provide contraception. And here are two examples, as I said, in the immediate aftermath. In Idaho, the University of Idaho said to its employees that they could no longer prescribe or dispense any birth control to students because they were worried about their underlying state laws and how it interacted with the Dobbs decision. Another example is there from Mississippi, where medical providers who worked with sexual assault survivors wrote to the Mississippi Attorney General and said, please tell us, do you consider emergency contraception to be abortion under our state ban? Are you going to prosecute us if we give emergency contraception to sexual assault survivors? So that was an immediate result of Dobbs' decision and these underlying abortion bans all of a sudden overnight becoming law. Another immediate response we saw to the Dobbs decision was some politicians finally kind of saying out loud what they wanted to do, which was to ban contraception, or at least express an openness to banning contraception. And so here are two examples in the immediate aftermath, one from Georgia Governor Kemp, who expressed openness to banning contraception, and one from a Michigan Attorney General candidate who said Plan B emergency contraception was no different than fentanyl and should be banned in the state. There was widespread backlash when they said this. People were outraged. And so what we saw, this was kind of the immediate, and then what we saw was that lawmakers started getting quieter about it. And in fact, there was a 2022 recording that press got of a webinar that anti-reproductive health lobbyists had with some lawmakers in Tennessee, where when asked about birth control, the advice from the lobbyists was, just keep quiet about that for 2 or 3 years. We kind of have to let things die down. People are so outraged about the Dobbs decision, just kind of hold on that for a while. And so that is what we have seen. In the past 18 months or so, we haven't seen the kind of full-on frontal attack on the right to contraception. But that doesn't mean we haven't seen any. We have seen attacks on contraception. But what we have seen is that it's a quieter strategy, but no less dangerous, I would say. They are just not being as overt. And we've identified 2 trends that I want to quickly cover. One is attacks on communities that are already made vulnerable in our society, and attacks that are happening through purposeful conflation of abortion and birth control. And in some ways, these attacks, these targeting certain populations, this misuse of science and data, it's following the abortion playbook. And so we're seeing that now, starting in contraception again. The way they chipped away at the abortion right, we're starting to see in contraception. So I'll just quickly cover these 2 strategies that we're seeing. In terms of attacking certain communities, young people has been a particular area where we've seen anti-abortion advocates and legislators attack birth control. And so from our friends at the Guttmacher Institute, we know in state legislatures this year, 8 bills were introduced in 6 states to require young people to obtain either parental consent or parental notification before they can get access to birth control. And we already talked in the last panel about how those kinds of requirements actually prevent people from getting the care they need. And then litigation, the thing I want to mention there is a suit that is out of Texas, where a Texas father filed a lawsuit against the Title X National Family Planning Program, arguing that minors should not any longer get confidential contraceptive care. That has long been the standard in Title X clinics. And this Texas father challenged it. And 2 things to note there. One is that his team of lawyers includes Jonathan Mitchell. And you all probably know Jonathan Mitchell as the architect of Texas's anti-abortion vigilante law, SB 8. So he is moving from his abortion attacks to birth control attacks. And the other thing I will say is that because of really hostile judges in Texas and on the appellate court, he was successful. And so minors in Texas right now do not have the ability to access confidential contraceptive care from Title X clinics. So these threats are not hypothetical, they are real, and they are affecting real people in this country. I'm running short on time, so I'll move quickly and say, in terms of the conflation of abortion and birth control, I'll give you one example from this year. An Indiana representative introduced a good proactive bill to try and expand access to long-acting contraception for postpartum Medicaid enrollees, and an anti-abortion effort came up and did carve IUDs out of that, falsely claiming that IUDs are abortion, not birth control. And that bill passed with that carve out in it. And so that is an example of this kind of false claims and this misuse of bad data, bad science in order to attack the right to contraception. So I should also say in this one, in fact, it's not only an example of conflating birth control and abortion, but it's also targeting a certain community because they're targeting low-income people who are on Medicaid. So the bottom line is they're coming after IVF, they're coming after contraception, and that brings me to the final thing I want to talk about, which is really the future of the law per this panel's topic. And so what I want to say here is that these efforts are not really about access to reproductive health care. What they really are about is a worldview that believes it's not only okay, but is actually necessary to take away certain people's ability to make our own decisions about our lives, bodies, futures, and families. And that it's okay and in fact necessary to end the government's ability to actually protect and support those decisions. And so that is a worldview that really is seeking to enforce really rigid gender roles and to control and punish women in particular, and I mean all women, trans women, cis women, intersex people who don't follow those norms. And that could be because they've had abortions. It could be because they don't have children. It could be because they are not married. It could be because their gender identity does not match their sex at birth. They have put this worldview out there. They have a plan for it. Project 2025 lays it out in great detail. You can walk through all the steps and the ways they're going to do it. They are going to recognize fetal personhood. They are going to dismantle all the protections we have in employment and healthcare and in education that protect us against discrimination. And they're going to, for example, make it harder for single mothers to get housing assistance. Like, it is a well thought out and very intentional plan across our entire society. And so what I would challenge us to do, and the second I have left, is really to put our vision forward, a vision that really connects all of these different things instead of playing the whack-a-mole that we often do in our community, where we fight this abortion ban over here and that contraception thing over there, and that we put forward our vision and our view for gender equality and gender justice that makes those connections and has the government really supporting those things. So I will stop there, but really looking forward to the discussion more later. Thank you.
Good afternoon. Let me say that again. Good afternoon. Sorry, I forgot. I'm a church person, so I'm used to call and response, definitely. Well, first of all, it's great to be here with you. I want to first thank Professor Huberfeld for that wonderful gracious introduction, and I'm looking forward to our discussion later. I want to acknowledge all of the fellow speakers. It's really a privilege to be on this panel with you. And I'm grateful for everybody in the audience. Thank you for being here, and the staff members who organized it, all the folks, all the tech folks. I have a good understanding of what it takes to put these events together. I also want to acknowledge the host, not only the Boston School of Public Health, but also Planned Parenthood, League of Massachusetts, and the BU Program on Reproductive Justice. Thank you to all of you. I want to start by talking really quickly about the National Partnership for Women and Families. We work on policies and legal protections that advance affordable health care, racial and gender and economic justice, and reproductive freedom for women and really all people in America. And our hope is that women in particular have an opportunity to reach their full potential and to live lives free of gender bias and barriers, and to care for themselves and their loved ones. We were founded in 1971, 2 years before Roe. And I want to use that as a little bit of a marker, because throughout our now 50-plus year history, we have focused on creating the legal and legislative infrastructure to ensure that women in particular were positioned to participate fully in society, equitably, and with the ability to control their own destiny. And we have pursued that work with a clear understanding that in order to secure protections for women, not only access to abortion, but also just to have other opportunities, that part of our work would have to be to disrupt a societal status quo that was built with very narrow views about the spaces that women could occupy legitimately, and was based on assumptions about gender roles and gender hierarchies. And I want to start there because Roe was an essential part of pushing back on that historical view about where women, the status that women held in our society. And it was part of an infrastructure that was constructed over time to afford women, at least theoretically, more autonomy to make their own choices, chart their own courses, and break out of predetermined boxes that limited their opportunities and their futures. And so I'm going to pick up where Gretchen left off and talk about the future of reproductive health policy and what we should look for. And I'm gonna make 3 points. When I first graduated from law school and went to a law firm, the first thing one of the partners said to me is always have 3 points. 2 sounds like you don't know enough. 4 is too many. People will get bored. So always have 3. So I have 3 points. So the first is I'm going to talk a little about just the need to counter the consistent erosion of basic fundamental freedoms and to think about rebuilding the legal protection infrastructure to ensure that folks can have access to reproductive health care nationwide. Second, I'm going to talk a little bit about protecting private health information and data privacy. And third, I'm going to talk about really transforming our healthcare system to be more holistic and more responsive to the diverse needs of women, and seeing reproductive health as a piece of that effort, as opposed to, the only thing that we need to do. So first, in terms of thinking about the future, is talking a little bit about what is the legal infrastructure that we need. And as I said, Roe, as we all know, grounded access to abortion in a privacy right guaranteed by the Constitution. And it theoretically enabled women to exercise individual freedom and to have more control over their bodily autonomy and health care. And I will take note, as our keynoter alluded to, I think there's a big discussion about whether Roe actually did that for all women, and particularly around race and ethnicity. Roe is not perfect, but at least created a legal baseline from which to build. It also helped to counter laws and narratives that had been used to limit women's rights more broadly for centuries. And together, Roe, with other sorts of rights and protections, the right to vote, the right to participate in the economy and work in jobs that women wanted, the right to access education, it helped fill gaps that existed in the law to create a foundation for women's full participation in society and in our democracy. And I say all that because I think when we talk about the future, we have to recognize that the task is to build something better, and that the task is not to go back to a status quo that was never built for women to have equity and equality. That's not how it was built, and Roe was part of the infrastructure that was constructed to fill those gaps, right? And it filled a piece, and only a piece. And so when we talk about the future and we understand Dobbs, the other thing that I think we need to recognize about Dobbs is that it did more than simply gut the privacy rights that were in the Constitution. It really reshaped the balance of power, and in particular, in eviscerating individual freedom that had given women more control over their health and handing it over to politicians. It gave more rights and power to the states to decide the scope of abortion access. And it played into what are entrenched power dynamics that exist in states that have always favored the political status quo. And in that context, it makes it harder to drive change. We did some research and found that when you looked at the states that have passed the most severe abortion restrictions, they are also among the same states with the most repressive voting measures on their books. And in fact, it is more likely that it's hardest to vote, I think 3 times more likely. In the states where it's hardest to vote, they are also 3 times more likely to hinder abortion rights for their residents. Similarly, if you just look at state abortion restrictions and women's representation in government, we found the states with the harshest abortion restrictions typically have the fewest number of women serving in their legislatures. And in contrast, the states with a higher percentage of women lawmakers are much more likely to have stronger protections around abortion access. And I lift up that research because it's a reminder that The protection of abortion access and individual freedom is part of a larger conversation about how you create an inclusive democracy. And I think when we think about the future, we have to recognize, as I started, that Roe was a piece of the infrastructure that we were trying to create more equity for women. And so when we think about the future, part of the repair is not only about abortion access, but it's also some other democratic reforms that enable people to participate in the political process. Second thing, I want to talk a little bit about the future of reproductive health from sort of a more technology standpoint. The reality is that, we have made enormous progress. There are great technological advances. That's amazing, and in particular, there's technology now that gives more access to folks who may live in underserved areas. They may be in rural communities, things like telehealth and so forth. But, with that technology and in a moment of regressive action by anti-choice lawmakers, there are also risks around data privacy. If you look particularly post-Dobbs, we now have new opportunities to authorize surveilling and prosecuting of pregnant people. I think folks have already mentioned the great work of Pregnancy Justice. I think they did actually come out with a report and at least did some initial presentation of their data post-Dobbs and showed a sharp increase in the cases of prosecutions of pregnant individuals. And so we have to be focused on finding ways for patients to use technology and technological advances like telehealth tools and data apps without that data being used against them. There are pending proposals in Congress that would address some of those issues, like minimizing the ability to access personal reproductive health data and make sure that it's not maintained on things like mobile apps and websites so that the information is not misused or disclosed prematurely or inappropriately. So that's the second area, in addition to thinking about a future that has more robust legal protections, that think more critically about restoring individual freedoms. The second area of the future has to focus on technology and data privacy. The third thing I wanted to say is talking a little bit about what it means to have a healthcare system that actually works for women. And what does it look like to actually transform healthcare in a way that ensures not only women, but really all people can access the care they need and when they need it. And I think part of what I wanted to say was that full access to reproductive health care is part of building a holistic, equitable healthcare ecosystem. Free of racial and ethnic bias and other sorts of biases as well. You have to be actually really intentional about health equity. It does not happen on its own. We know that focusing on health equity is particularly important because long before Dobbs, as I think our keynote presenter said, the inequities in the healthcare system were very clear and produced deep disparities along racial and ethnic lines. A few of the data points: Black and Native American women more likely than white women to live in states where abortion has already been banned or likely to be banned. Roughly 1 out of every 6 Black babies born born in an area with limited or no access to maternity care services. And Black and Indigenous women are 3-4 times more likely than white women to die from complications around pregnancy and childbirth. Those are a few of the data points that are a reminder that health equity is a priority, and we have to be intentional about addressing it and be intentional about creating a healthcare infrastructure that actually is responsive to the needs of all patients, and reproductive health care is a part of it. So I'll stop there. But I want to thank you again for your attention, and I look forward to the conversation.
Thank you. It's a real pleasure to be here today. I also want to thank BU and the School of Public Health and the law school for holding this really important conversation right now. I am a stealth public health person on this panel. I'm actually not a lawyer, and I was trained in health policy research in a school of public health. Not BU, but it's really a delight to be here today. And I'm going to focus my remarks on the ballot initiative. You know, we've had so much discussion everywhere about abortion, and particularly related to this election. And so I'm going to talk about some of the opportunities and the realities of these ballot initiatives. But I want to say that we are very focused on this election right now, but this is an arc that we are facing right now. And the work to dismantle Roe started practically the day after Roe was decided, and we had conversations about Hyde. Hyde was the beginning of that, and that was soon after. And so I think that while we're focused on this election, I think there needs to be a bigger, long view discussion about what we do. I mean, I think this is an important starting point that we as a nation are having right now. But I think that, you know, each is a little step, but I think we really need to have a long view focus. So with that, I want to start. I am Alina Selganikoff. I work at KFF. We are a health policy, research, polling, and news organization. We were formerly known as the Kaiser Family Foundation, but it became very confusing because we have nothing to do with Kaiser Permanente, and we are no longer a foundation, and we have no family members. So really, we spent some time thinking about what would be a good name, and you know, after a lot of creative juices were spent, we came up with KFF. So here we are. So with that, I'm going to get started. So we do a tremendous amount of survey work, and this is from some data that we collected. Actually, it's a survey of women that we do every couple of years in May. And you may have heard Trump say that taking abortion back to the states is a beautiful thing, and that this is what people wanted all along. And I'm here to tell you that what we hear from women is, yeah, no, they don't really want that. As a matter of fact, when you ask women of reproductive age whether they support taking it back to the states, 3/4 overall say that they do not. And when you look by party ID, in fact, of course, not surprisingly, Democrats are overwhelmingly opposed, but also so are Republicans. Now, I will say that a share of those Republicans feel like taking it back to the states is not enough, that they would like a national ban, but actually when you survey them about whether there should be a national right to abortion, just under half say that there should be. So that there are several, about half of Republican women are also supportive of abortion rights. So let's see here if I get this. So when we look at this map and taking it back to the states, this has become a very, very appealing option, is to do these voter initiatives. Some of them are later legislatively initiated. And we've seen since Dobbs, 28 states attempt to place abortion-related measures on the ballot, trying to take it back to the voters. So far, 6 states have voted. 4 of the states, California, Vermont, Ohio, and Michigan, have enshrined the right to abortion in their state's constitution. In 2 states, Kentucky and Kansas, voters actually defeated measures that would have limited abortion, even though abortion can still be very restricted in those states. This November, as you heard, 10 states are going to vote on abortion-related measures. Nebraska is going to vote on 2 measures. They're competing measures, one to protect abortion rights up to the point of viability, and the other one which would ban abortion basically after the first trimester, as they're kind of more progressive common sense approach. The other states are voting on measures that would protect the right to abortion, but there are some important differences in how the measures are worded. But I just want to say that it's been kind of like hand-to-hand combat getting these measures to the voters. Along the way, there have been so many efforts to block them or to stop them from succeeding. Some of these attempts have included moving the goalposts, so changing the number of signatures that are required to get the abortion on the ballot, or changing geographical requirements for the signatures, or trying to change the actual percentage of signatures that are needed to get it on the ballot. And that was the case that we saw in Ohio that was also ultimately voted down. We've seen attempts to have biased language in the voter pamphlets. So in Arizona, the summary says that the fetuses are referred to as unborn children. In Missouri, the Attorney General drafted language that was ultimately struck down that would have allowed for saying that these prevents dangerous abortions until births. So, I mean, these are cases where we're really seeing a lot of distortions and manipulation. There are other cases where signatures have been invalidated. In Arkansas, the Secretary of State ultimately rejected a citizen initiative even though they had enough votes. And we saw that in Montana, the Secretary of State unsuccessfully attempted to disqualify signatures from inactive voters, even though you don't have to be an active voter to actually have your signature count. And I already referred to the competing measures in Nebraska. Of course, the attempt is to confuse voters. One protects abortion and the other one protects women and children. So, you know, there's a lot of kind of distortions and misinformation that is being used and conveyed to voters. And we just saw, just a couple weeks ago, there was an 11th hour attempt in Nebraska and Missouri to actually stop the presses from the ballots getting through, but those were ultimately rejected, and those will both go to the votes. And then, of course, in Florida, as you've probably read, police are now knocking on doors of voters' homes to question them about whether they signed the petition for the abortion rights amendment. So the chilling effects are very real, and the attempts to block these voters, the will of the voters is also really real. So when we did our survey, we suspected that there may be approved ballot initiatives in Arizona and in Florida. So we took the opportunity to do an oversample to get a better sense of what the experiences and attitudes were among women who lived in those states. And so, as you know, in Florida, there is currently a 6-week gestational limit. It was a 15-week. Florida was a critically important place for women to get abortion in the South, as Ushma knows the data so well, and so losing Florida really was a huge hit to not just those who live in Florida, but pregnant people throughout the South who are seeking abortion. So the amendment would protect the legal right to abortion to viability when necessary to protect the patient's health after viability. It does not change, and I'm noticing we had this discussion about parental consent because this has been an issue that has been raised in the efforts to block this initiative from moving forward. As Benita Miller mentioned, it's 60%. You need 60% of votes. That's a pretty high bar. I would say that in only 2 of the prior initiatives exceeded 60%, and that was in California and Vermont. So that is a very heavy lift. We'll see how many voters actually turn out in Florida. So, and when we asked women in Florida about their experiences and attitudes, 18% said that they had had an abortion, and there was no difference between the shared Democrats and Republicans who had had abortion. This affects all women equally. 34%, to the points that were raised earlier, said that they did not know where they could get an abortion or find the information about where to get an abortion, and 62% said they were concerned about the impact of abortion access and what that would mean for the future of the safety of a future pregnancy. So the messages are getting through about the real risks that are happening, not just to women who are kind of seeking abortions, but those who have pregnancy-related emergencies and cannot get the care that they need. That includes abortion as well. Similarly, in Arizona, Arizona has a 15-week ban. You may remember that they actually had a law that was an abortion ban that, 1 minute, really? Okay, I'm going to go fast, sorry. Similarly, we saw a lot of confusion in terms of where to get an abortion. 40% said they didn't know the status of abortion in their state. Not surprising given the back and forth that was there. So what is this going to mean, having these? This is a map that you've all seen kind of different versions. KFF has its own version, but there's kind of some similar patterns that arise in all of these. So if all of the measures passed, it's going to look like this. So we're going to have 5 states where abortion is restricted, which will have abortion available beyond 22 weeks. But I think that this is an important map to also look at, which is what happens in the states where abortion is banned. These states, many of these do not have a mechanism to get a voter-initiated amendment on the Constitution. We heard in Arkansas, they tried. Oklahoma and North Dakota are 2 states. I know that there's current litigation right now in North Dakota. These are states that didn't really have a lot of abortion providers before Roe. And so this is, I think, a limited tool. We'll see how it affects the vote. And then finally, I just wanted to close with a point that I think we've been having quite an important discussion about abortion access, even in places where abortion is supposedly protected and available. We asked women, how easy is it for women to get it in your state? And then we were able to stratify by state of residence. And not surprisingly, in states where abortion is banned, people thought it was, the vast majority thought it was difficult. But I want to point you to the bottom there where there are, very late gestational limits or at viability or none, and still 1 in 5 women said that it's difficult. And so I think it gets back to some of the earlier points that we were discussing about what can we do in blue states. One is there is a lot we can do to make abortion more accessible in our states, but in addition to that, throughout there's a lot of education and information that needs to be conveyed to people about where to get their care. So with that, I will wrap up. That's it.
Hello. Can that be blacked out for the first beginning? I don't have a keyboard to do that. Okay, good, thanks. So good afternoon. I'm David Cohen, a professor at Drexel in Philadelphia, and I want to really thank the people for organizing this, everyone involved in putting today on and having such a great discussion, and all the people who've gone before me with their wonderful contributions as well. So I'm here to sort of be, as the last one, I figure I'm going to talk about sort of opportunities that are presented in the future. And I want to do that by starting to look at state Supreme Courts, because people have been talking about state Supreme Courts as, well, we lost the US Supreme Court with Dobbs overturning Roe v. Wade. Well, maybe now state Supreme Courts are an opportunity for us to present a different look about reproductive rights and justice than what we saw from the US Supreme Court. And the story that we've seen with state Supreme Courts is a mixed one. So I'm going to start with the bad, and then we'll get to the better. So starting with the bad, if we can get to my first slide then. There we go. So we've had a lot of state Supreme Court cases. And this map is a map of state Supreme Courts, or state trial courts too, but it's mostly state Supreme Courts that have produced anti-abortion rulings. And so I don't have enough time to go through each one of these, but I want to highlight a few or provide some lowlights, I guess, on this slide. South Carolina, I want to start with South Carolina. South Carolina, after Dobbs, had a 6-week abortion ban. It was immediately challenged in state court, and the South Carolina Supreme Court came out with a really wonderful opinion explaining how there's a right to abortion in the state constitution. It was a 4-3 decision, and it was, I think, the first decision from a state Supreme Court post-Dobbs, and it was this signal, maybe there's going to be this promise from state Supreme Courts that we weren't expecting, right, because this is South Carolina. Unfortunately, soon after that decision, the Chief Justice, the only woman on the South Carolina Supreme Court, retired because there was a mandatory retirement age, and she was replaced by an anti-abortion male justice. And they reheard the case almost immediately, and 6 months later, they flipped and said there's no right to constitute abortion in the South Carolina Constitution. So we think of Roe being flipped 49 years later. Here we have a case 6 months later overturned by the same court. And now there is a 6-week ban in South Carolina because of the state Supreme Court's flipping on this issue. We saw something similar in Iowa, although not the same time frame. But the Iowa Supreme Court had really been an interesting beacon of progressive rulings, one of the first to rule for same-sex marriage. They had ruled that there was a state constitutional right to abortion. But Iowa Supreme Court is also justices are up for retention and re-election. And these became major issues in Iowa politics. And some of the justices who were involved in some of those decisions from earlier were replaced, and the Iowa Supreme Court has become more conservative. And just earlier this year, the Iowa Supreme Court reversed its ruling that there was a state-protected constitutional right to abortion, and now there's a 6-week ban in Iowa as well. Two others related to what Alina was just talking with ballot initiatives. The Florida Supreme Court ruled that there was no constitutional right to abortion, also reversing a previous ruling from the Florida Supreme Court, allowing a 15-week ban to go into effect. But in doing so, Florida legislators had passed a law that said we want a 6-week abortion ban, but will only go into effect if the Florida Supreme Court approves our 15-week ban. So when the Florida Supreme Court earlier this year approved its 15-week ban, the 6-week ban went into place. And now we have a 6-week ban, but that may be overturned with the ballot initiative in November. Arizona Supreme Court approved an 1864 territorial law enacted before Arizona was a state and approved that and said that applies today. And the legislators in Arizona, there was such quick backlash about that case that the legislators in Arizona repealed that 1864 ban, but also there's a ballot initiative that could, Arizona currently has a 15-week ban, so it will increase the gestational limit in Arizona. But it was a lot of that's in response to the Arizona Supreme Court. On the flip side, we have some really good decisions from state Supreme Courts. And I want to just highlight a couple here that are some surprises in Utah, Wyoming, Montana, North Dakota. North Dakota is not the Supreme Court, it's the trial level court. All and Kansas as well. It is because of the state courts that we have some semblance of abortion rights in those states. Now, North Dakota is in flux right now because there is no abortion clinic in North Dakota, even though the North Dakota court just ruled a couple weeks ago. So it's not like there's abortion provision happening in North Dakota right now, and that's going to be appealed to the state Supreme Court. But we have some surprising decisions, and I think it's a sign that there can be some really interesting decisions from unexpected places from state Supreme Courts. Or in state courts generally. Ohio is a really interesting one because the people of Ohio passed their ballot initiative last November, and it has already been used to get rid of many abortion restrictions that had been in place, so not only increasing the gestational limit from 6 to 24 weeks, but also getting rid of burdensome requirements that had previously been before Dobbs in place. So the clinics in Ohio are able to provide better, more evidence-based medicine abortions now than they were before Dobbs because of the ballot initiative in that state. And Nevada and Pennsylvania, just quickly highlight them. There have been challenges to the Medicaid ban, the Hyde Amendment, the state version in those states, and Nevada just recently finalized their case saying that that is unconstitutional under their state equal rights amendment. And in Pennsylvania, in a case that I'm currently litigating, we've been litigating it for almost 6 years at this point, we successfully challenged our Medicaid ban and got a case overturned in the Pennsylvania Supreme Court, although we have not finalized that case. That still have some things to play out in the lower courts. So there's opportunity in state courts, but there's also opportunity in state legislation. And so we've already talked about shield laws, and I'm just going to briefly talk about these. There are 3 different types of shield laws that are out there. There are shield laws in the yellow states that protect people who travel into those states and the providers who provide care for them so that they cannot be prosecuted or have any civil repercussions for providing care for people who travel to those states. The blue states, it's not legislation, they're executive orders from governors that have similar, although not the same strength of protections, because those states don't have the legislatures that could pass those. And then the orange states are the states that we've heard about, that Ushma talked about in terms of the telehealth provision. The orange states allow their providers to use telehealth to care for patients who are in other states, including banned states. And the providers doing so in those orange states will not lose their state licenses for doing that. And they are protected from extradition, and they are protected from other civil consequences for providing that care. And there are providers doing this, mostly in New York, California, and Massachusetts. Massachusetts was the first state to have this kind of law, and so it's a pioneer in this area. Massachusetts, New York, and California providers, a very small number of them are providing a very large number of abortions, mostly into states where abortion is banned. And so it's a large part of the story of why abortion has continued post-Dobbs. And so there's opportunity in expanding these shield laws to more states, and then also turning some of those yellow states into orange states so that they can be more telehealth provision and protection for providers in those states. And then also making, there are 11 of the states that have these protections also protect providers of gender-affirming care, and so expanding to be all of these states protecting providers of gender-affirming care. More legislative opportunities. Nationally, there's legislative opportunity in repealing the Comstock Act. The Comstock Act is an 1873 law that was passed promoted by Anthony Comstock, who was opposed to sex, opposed to women, basically opposed to anything involving things that he deemed immoral. This law is still on the books. And as you can see, what it does is it prohibits mailing with 1461 and the use of express mail, private express mail, 1462, anything that produces abortion. And for a long time, no one really thought about this law because in the 1920s, 1930s, the federal courts, not the Supreme Court, but the intermediate appellate courts pretty much said this law only applies to illegal abortion, producing a legal abortion. Well, now, post-Dobbs, the anti-abortion movement is looking at this law and saying, wait, the law doesn't say anything about illegal abortion. It says producing abortion. That's it. So that means you can't mail anything, this is their argument, you can't mail anything that produces an abortion at all. So that would include abortion pills that are mailed, but not just abortion pills. It would also include instruments and supplies used by abortion clinics that produce abortion. And so this argument from the anti-abortion movement has gone from the fringe of the anti-abortion movement into the very mainstream. There were about 153, I believe, members of Congress who signed onto a brief in the case before the Supreme Court about medication abortion that was dismissed for lack of standing earlier this year. Members of Congress signed on to this brief advocating for this understanding of the Comstock Act. There are 2 bills in Congress to repeal the Comstock Act, and they have been greeted with a lot of silence, which shocks me because everyone should be on board with repealing this law from 1873, especially because it also includes not just things that produce abortion, but anything that is indecent or immoral. And leaving that up to an attorney general who might view a lot of things that we care about as indecent or immoral is really risky. Finally, on the state level, legislative opportunities, the anti-abortion movement is working on reducing gestational age limits and tinkering with exceptions in a way that you might say to yourself, if they improve the exceptions, that's a good thing. Well, yes, for the people who that cares for, but in reality, what it means is that they are able to make the laws look more palatable to the public without really expanding abortion much for anyone. On the pro-choice side, expanding shield laws, I talked about that, looking at restrictions that exist on the book, like Massachusetts' requirement that people under 16 get parental consent and removing those. States have been doing that for the past 2 years in ways that we've been begging them to do for decades, and Dobbs has inspired a lot of states to get rid of restrictions, and there's a lot more that can be done in that regard. And same with providing funding for travelers, funding for patients, funding for clinics. Again, people have been begging states to do this for decades, and Dobbs has motivated pro-choice states to provide funding for abortion, abortion providers, abortion seekers, abortion helpers in ways that we had not been able to get them to do before. So I'll stop here and we'll continue talking now.
I'm going to go ahead and invite our panelists to come on up. And we've asked Benita to join us as well because we figured people might have questions for her too. While we settle in, just a reminder to our virtual audience that you are welcome to submit questions through the Q&A function on Zoom. But we'll begin with our in-person conversation. And I want to bring it back to the theme, which is voting for health. And of course, there's a really important thread here that we should pick up, which is that we need to not just think about the current presidential election, not just think about the short term, but also the midterm and the long term as well. But to start with the short term, there's a kind of a common narrative today that Congress can't get anything done. And so if we accept that as true, and I would push back on it a little bit myself, just to use the example of, say, relief bills during COVID as a counterfactual, but Congress is slow. What can a president do, and how does it matter to the conversation we're having today? And I suspect this is something each of you have thought about. So maybe I'll just walk down the line to get us going.
The current president or the future president?
President. President.
Well, I'll defer to the panel. I'll listen to you all.
Well, we can all probably talk for forever about this. And there's an effort among the federal groups that do reproductive rights and health work to put together a version of asks for the administration. We had one for the last administration. It's called the Blueprint, that puts in detail all of the things that the administration should do through all the agencies and all of that. The thing I think I want to mention here is the bully pulpit role of the president, right? The way they can use their power as their profile to really elevate these issues. And someone, I can't remember, sorry, who put it up, but Vice President Harris visiting an abortion clinic. That is powerful. And talking about this issue in a way that grounds it in the real lived experiences of people who are having these restrictions forced upon them and facing the real barriers that exist. I think that is a really critical role. Biden himself has not been great at that, let's be honest, but I think Harris has been, and I think that's a really important role for the president to play that bully pulpit role and to really flip the conversation and talk about it in new ways that resonate with the people who are experiencing the barriers.
Yeah, I completely agree. I think the other thing that's important for the administration, and I think they have done some of this, is to really push back on the overreach. I think one of the things that was clear after Dobbs is that it sort of freed up lawmakers, anti-choice folks to do all sorts of stuff and a lot of crazy stuff. And not that most of it isn't crazy to begin with, but things that like the right to travel, And then people saying, well, we can stop people from traveling to another state. Well, no, actually, you're not supposed to be able to. And I think the administration really quickly, and the Attorney General saying, there's a constitutional right to travel, and we'll jump in and oppose it, also helps. And so I think, you know, in a moment of a lot of really excessive overreach on the part of lawmakers across the country, it's important for the administration to step in and say, we're going to hold the line here, we're going to step in, we're going to litigate, we're going to intervene, we're going to protect federal protections like EMTALA and access to mifepristone and the ability of the FDA to make decisions like it matters. You know, the government is one of the biggest, you know, law firms in the country, and they need to utilize that skill set. So I think that's really important for the administration. In addition to centering this conversation in the broader conversation about access to health care. I think one of the flaws of Dobbs, of the many flaws, was this idea that you could eliminate access to abortion and it would affect nothing else, right? And I think being able to tell the story over and over again about the broader reverberations and how it is situated in the context of healthcare writ large is really important for the government to say.
I completely agree, because I think that the issue is that this administration, even though some have wanted them to do more, and Biden's discomfort with abortion has been obvious, they have been very strongly defending you know, the right to abortion and around privacy and HIPAA and EMTALA and mifepristone, and you kind of have to think about what happens, the flip side, if you actually have an administration that isn't protective, you know, what kind of gates are opened in terms of that. I think there is more in terms of information. They do a lot of work around information around pregnancy, and you look at the CDC sites, there's a ton of misinformation that is actually circulating. I think that they could play a stronger role in providing good information or supporting groups that are providing good information so that there are more trusted sources out there. There's been a lot of kind of distortions, some that have been intentional and some that have been spinning out of their own orbit on TikTok and other things. And then I think the other part is also supporting not just abortion rights, but, you know, reproductive rights. And they've been very invested, I think, on maternal health. But, you know, let's be clear, this is like a phase of, you know, your life, right, as a woman. And, you know, before you get pregnant, there's a lot that needs to happen. And if you decide you never want to be pregnant, and then beyond. So what, you know, they could do to kind of reinforce education, information about these, and also support in healthcare services.
David.
So I'll say three real quickly, and a fourth I'll talk a little more about. One, get rid of restrictions on medication abortion that still exist. Two, vigorously enforce EMTALA against hospitals and providers who do not provide abortions for people who come to who need an emergency abortion. Three, promise to veto any budget that includes Hyde. Four, and this one I'll talk a little more about, talk about Dobbs as short-lived, and talk about Dobbs as being overruled in the near future. And I think that too many people in government and advocacy talk about Dobbs as if it's set in stone. Nothing is set in stone. Nothing from the Supreme Court has ever been set in stone, as it always contested. And we talked about the anti-abortion movement from day one, fighting Roe. From day one, they talked about Roe needing to be overturned. Our movement very infrequently talks about overturning Dobbs. We talk about Dobbs as if we have to live with it forever. We do not. We do not know the future. We do not know when we are going to get new justices on the Supreme Court to overturn Dobbs. It could happen in 50 years. It could happen in 20 years. It could happen tomorrow. None of us knows the future about anyone serving on the Supreme Court. And we need to talk about Dobbs as if it was not only wrong, not only problematic, but also short-lived, And we are going to make sure that the moment there's an opportunity to overturn Dobbs, we take that opportunity and we do it. And we do that by having people in the pipeline who are judges who will overturn Dobbs, who will not just care about precedent and say, well, Dobbs is precedent, got to follow it. 2, we have cases in the pipeline so that the moment we have an opportunity, there's a case pending cert at the Supreme Court ready to overturn Dobbs. They had cases constantly that they knew were going to lose. They lost for 49 years, but then the moment Ruth Bader Ginsburg died, they had a case in the pipeline that was used to overturn Dobbs. It wasn't the 10th case after they flipped the court. It was the first case, because they had cases in the pipeline. We need cases in the pipeline to do that immediately when that opportunity comes, whether it's tomorrow, 20 years, or 50 years from now.
I think these are terrific answers, and they reflect something that's come up repeatedly in our conversation, which is that there is a distinction between what law formally says and the impact that law has on the ground. So can we talk about that a little bit? How do you address that distance, the chaos and confusion that keeps coming up in our conversation? And I know one answer might be better communication, but how do we make it clearer what the law actually is, how it can be changed, how quickly it can be changed? Because I think there's a mystery there that needs to be overcome. What are your thoughts on that?
Okay, I can start this time.
Thank
Because
you.
I was like, I cheated and heard all y'all answers. But I would say this, like hearing everyone talk about having worked in government, I think going back to the question about what a president can do is have a more collaborative approach around their appointments, their cabinet appointments. And at a state level, I think about how does the state government advance some of the policies, because the things that come down from the federal government, you kind of adopt them and craft them to your state environment. So I do think that is also critically important as community in the state to really think about who's being elected, who are they appointing to key positions that articulate how policy and practice is implemented on the ground. And I think that we pay, and I think to your point, anti-right movements, they have done that more assertively, figuring out how to move their state governments, making sure they know who are not just on the judicial side, but who is actually implementing and determining how policy is practiced.
Mm-hmm. Anyone else want to jump in?
I mean, I'm happy to jump in. You know, I have this sticker on my water bottle that says legal is not accessible, which came, I think, from Apiary, which is a practical support organization that helps people get abortion care. I mean, I think we have long invested in the rights part of the reproductive rights, health, and justice movement and getting the formal laws in place and the rights in place. And there has not been enough investment in the reproductive justice side of the movement, which is really working with the communities and working with the people and folks on the ground. And so I think that balance is starting to shift a little bit, as it rightly should, and that we need to continue to do that and make sure that the pathways between the community-based work is really connected to the policy making that is going on, so that the rights are informed by the real access barriers on the ground, and that the access barriers are helping to inform the policy. And I think there are, as I said, it's gotten better, I think, but I think there's still a lot of ground to cover. And in part, it's the funding community needs to really think about how they're investing and making sure they're investing in those communities.
Yeah.
Well, I also think about the so-called exceptions to the abortion bans that have been, you know, kind of at the heart of all of these cases that we've heard about women experiencing harm and death, you know, that they were saying, and the responses that the legislators, the anti-abortion legislators, or it's in the law, they're just, the doctors are just not following this. But, you know, you can't have a law that actually deals with implementation issues. And I think that some of it is written vaguely intentionally. Mm-hmm. And I think that we cannot underestimate the power of a chilling effect on clinical care, on institutions, And so I think that the legal part of this, you know, they write the law, they pass the law. Remember years ago, I was trying to do a map on penalties in abortions or gestational limits, and it was for JAMA, and they kept saying to us, well, this is not language that is like in the, you know, it's not medically accurate language. I'm like, who do you think is writing? You think a bunch of doctors are writing these laws? Yeah. These are legislators, and we already know many of them have very openly expressed their own ignorance on many of these issues. So I think that the chilling effect is part of that. And I think also recognizing that, you know, it's the first step. The law is the first step. But there is so much more in terms of implementing the protections.
Well,
David, Jocelyn, go ahead.
Yeah, I mean, I will say, just building on that point, I think that people often don't understand what implementation and enforcement looks like. And it often requires resources, it requires money, it requires you to set aside a budget in terms of staffing, educating staff, and so forth. And so I think, you know, one of the fundamental critiques of Roe was that, you know, there was a protection in principle that always wasn't felt evenly and consistently across many racial and ethnic groups. And in part, it's the point that Gretchen raised earlier, because on the ground, this looks different. And if you're not actually focusing on implementation in the context where people live, then it may have limited reach. It's one thing if people have facilities and providers, you know, 5 minutes away. It's another thing if the providers are, you know, 2 days away, right? And I think, you know, part of the work of implementation is being able to think really intentionally about how do you feel and experience these protections on the ground across the board. What does that look like? And what else is needed to ensure that people actually are able to experience those protections? And that is an ongoing process and takes work, including whether or not people are willing to enforce it in the first place, right? Like, that's the other thing. You know, we, both the partnership and the National Women's Law Center, worked on the Pregnant Workers Fairness Act and went through a lot to get pregnancy protections or pregnancy discrimination protections for workers. And as soon as the regulations were released, they got, you know, Texas sued, right? Because people don't, because of an interpretation that has to do with abortion that actually has been an interpretation for a very long time, but in this moment has become a lightning rod. So it's all about, I think, recognizing that the work sometimes doesn't get started until after you pass it.
David.
So I think one of the challenges with implementation is the difficulty of messaging for change in social movements versus the reality on the ground. And so sometimes we overstate the impact of something the Supreme Court does or a law in order to get people riled up. And it's very different than what's on the ground in some places. So for instance, when SB 8 passed, right, what was the message? It was going to end 90% of the abortions in Texas. It was going to be before most people know they're even pregnant. The reality on the ground is that it's reduced abortion by 50%, or SB 8 when it was 6 weeks. And that's been true in other 6-week states. And I think actually in Florida, it was only reduced 35%. And so when people are trying to implement these really terrible laws, and if they hear the messaging that's meant for social change, which is that this law is terrible, it's extreme, it's, you know, in all the different ways, and then they think, well, I guess I can't get an abortion in Florida because, you know, everyone said this is going to end most abortion in Florida. But the reality is people on the ground are providing abortion. They are getting patients in quickly. They are counseling them quickly. The providers are doing heroic work. The funds are doing incredible work. The practical support groups are doing incredible work. The telehealth providers are doing incredible work because they are not listening to our messaging for social change, and they are just saying, we're going to get this done. And it's the same with exceptions in some places, right? Exceptions are a horrible way to do policy, but there are some places where exceptions work. And they're not getting everyone abortions, far from it, but they're getting a lot more people abortions than you would necessarily see when you see people say that exceptions don't work. And so I think there's a challenge there, and I don't know the right answer for that. I think it's really hard because we need to say things are dire in order to get people to listen. But implementation on the ground needs to deal with the nitty-gritty reality of reading this law as narrowly as you're comfortably reading it for your own risk. And there are a lot of people who are really comfortable reading laws really narrowly and and are not risk averse and providing care to the extent possible with a narrow reading of the law, which goes against our broader reading to try and get people to think about the necessity of voting and change.
So I want to make sure that we open it up so that we have time for questions from the audience, both live and online. So I see that we have a question over here. Is there a microphone available?
We've been talking about how Roe v. Wade was really a privacy issue, and privacy is extremely important. But this has become an equal rights issue, and an equal rights for the Michelle in Texas versus the Michelle in Massachusetts that Dominique spoke about. It's not the equal rights for a fetus. It's the equal rights for women everywhere in this country, and we have to focus on that. Donald Trump should not have sent this back to the states, not when 22 states ban abortions completely, leaving the other 28 states doing whatever they want. We need a basic right protected at equal rights level.
Thank you for your statement. Is there a question in there?
How can we implement this, okay? How can we get this back? I mean, I don't know that Congress isn't going to overturn Hyde on when they can't even pass a budget. But, you know, is there any way we can get this codified until we can get a better Supreme Court that can overturn Dobbs?
So, David, maybe you want to talk about this because some of the state Supreme Court litigation is equality-based. Do you want to say a few words about that?
The Nevada case and the Pennsylvania case that I mentioned are both based on their state equal rights amendment, and New Mexico has a case from the 1990s that's based on its equal rights amendment, making the argument that you're making. And really going deep into the notion of stereotype expectation of women to be mothers, and saying that this is an issue of equality. So far, the U.S. Supreme Court has rejected that argument, but again, nothing the Supreme Court's done is ever written in stone. This is all contested, and we can change it in the future. And so people are continuing to push this argument, and one day, hopefully, it will win.
Gretchen, have you also spent time thinking about the equality argument?
We have spent a lot of time. You know, I think we would like to see a new constitutional amendment and just go straight to the people on it, right? A new gender equality constitutional amendment that explicitly names abortion, so there can't be the situation where someone reads it out. We started to do some research with the public to see if they were open to the idea, and they are. I mean, some people, like white cis men, are like, Constitution's good. We don't need to tinker with it, right? But younger people of color in particular, they get it. They're ready to see that kind of thing. So I think there's some hope there, but it's certainly this is like our 30-year plan. This is not an immediate plan.
That is a long-term plan.
That's a long-term plan.
Because amending the Constitution is extremely hard, purposefully. Right. But if you do, you are amending everything that came before. So it would be a big deal. I see there's an online question.
Yes, so this question someone submitted, there's someone of the post-Roe generation who says, I admit that I took my reproductive rights for granted, but in short asks what org or orgs are kind of holding and steering the antithesis of Project 2025?
Wait, can you repeat it?
I'm not sure I understand the question.
Yeah. So I think they're just asking
what's our response?
What orgs what orgs, organization?
What's the pro-abortion or pro-choice alternative to Project 2025? Who's writing that? Well, I mean, your blueprint is part of that response.
Right.
Yeah.
Do you want to talk about broader progressive?
Yeah.
Yeah, I mean, I'll talk a little bit, you know, the Law Center actually just came out with a great report that talked about Project 2025. I mean, I think there's a multi-pronged answer. You know, there clearly is a broad progressive effort to think about, you know, what are the steps needed to actually not simply overturn Dobbs, but what actually needs to be in existence to give people access to reproductive health care, including access to abortion. And there's a broad coalition of groups who work on women's rights, reproductive justice, who have been thinking about that and working on that. And I think hopefully there'll be an opportunity to elevate that. But I think part of the broader question is, is there sort of a robust, sort of Project 2025 effort that is progressive? And I think the answer is, my personal view is that that work has always been underway, right? Like, I think across many of our movements, people have been working and thinking about where should we be going, not simply sort of more reactive, but what does a proactive vision look like? And so I think that work is happening across many different organizations, not just the women's rights community or folks who work on abortion access and reproductive health care. And I think what I'd say is particularly important over the past year, and in many ways Dobbs, along with some of the other Supreme Court decisions around voting and affirmative action, have been a real reminder to folks that we have a shared interest, right, across multiple movements. The folks who are going after abortion are also going after LGBTQ plus rights. They're going after voting. They're going after they're doing all of the things. And so many of us work in coalitions across multiple issues, recognizing that we have a common threat. And people have talked about it, have used the term democracy, but I think it's really just about freedom, right? It's about actually protecting our freedoms, and I think folks are committed to doing that. So it may not appear in one nicely well-resourced blueprint, but I think the work is there.
I don't know about you, but I could listen to these people talk all day. Unfortunately, we do have a time limit. So could we please thank our panelists again?
Please join me in thanking our moderator. A thank you to everybody who spoke today. Thank you to everybody who was involved in organizing this really outstanding set of panels. And a thank you to everybody in the audience, both in person and online. Thank you for everything that you do and for giving the time to these ideas, both towards generating the data and science and to thinking about how best one advances the ideas to promote health. Everybody, thank you. Have a good afternoon.